You are now
Does
unmuted.
everybody hear me okay? I heard Max say he needs to ask a question, but then nothing after that. Wondering when the quiz from this weekend will be available for review. I can make that available for review right now. All right, that should be all things trauma. This weekend coming up is not what you're asking, so I'll go on from that. All right, this is the last week of trauma, so do remember that we will take trauma module not this week during lab, but next week. All right, you have 4 chapters this week, 30, 31, 32, and 33. That's chest injuries, abdominal and genital, urinary, GI-ish involvement, orthopedic injuries, and environmental emergencies. Can you guys tell me if the medical, when you were doing adaptive testing, did the medical module ask you environmental questions? I think I remember that being the case. Did they try to throw chapter 33 into the medical module during your adaptive testing? That's my question. If anyone remembers that, speak up. Okay, good then. Thought I remembered one of you saying that that had occurred. Pulling up the slides here. It's going to be a busy night, so we'll get going pretty quickly. Our breaks will be about 5-minute breaks, if at all possible, so that we can get through everything. Of course, if you have questions, please speak up. Try to remember to throw in lecture assignment questions here. Also, I put some house cleaning items in the group me. I discussed the importance of discussion boards. Even if it takes me 2 or 3 weeks to grade them, I will grade them, and they're going to post. So I know that you're busy. I know you have other things going on. I completely respect that. I applaud that. You guys take on a lot. Most of you are pre-med students, but that does not escape the requirements of this class. And so you've got to put your time management skills together to make whatever happen. I get it. I do. I have a 4-year degree myself. I have an associate's before I had that. I get it. However, you got to find a way. And I know you will. And some of you kind of fall short some weeks, and that's okay. I'm not one to, pretend that 1 week is the entirety of this course, but please, some of you that are really good students have had some hiccups, and it's a little surprising. And so I'm just reminding you to get back to it. We're coming off a spring break last week, and so maybe that was accounting for a little bit of the difficulty getting back into the grind. So let's do whatever we need to do to get back into that grind. So discussion boards are going to keep posting. They're really important. Again, I'm not posting busy work. I'm posting stuff that you're going to need. Last week's discussion on spine motion restriction and the topic that goes on around that is a very big topic right now. You're going to find services that are even debating one another on that topic. And so you need to be able to converse. You need to be able to apply that topic to your practice. And so that discussion board from last week was really important for that reason. The discussion this week is also going to be important. Can everybody else hear me? Can everyone else hear me? Crap.
You are now muted. You are now unmuted.
Can you guys hear me now? All right, let's try it again. Can you hear me now? How annoying.
Yeah, I hear you.
Can you tell me where I left off? Can you tell me what the last thing you heard was? Because I was doing all kinds of talking.
I didn't really hear anything, honestly. Not from anything.
I didn't hear either.
All right, starting over. This week's chapters are chest injuries, which is 30, abdominal and genital and GI, which is 31, orthopedic injuries, 32, and environmental, 33. My question is, did you guys get environmental questions during your adaptive testing while we were in the medical module? Can you remember back to when the earliest point you think you saw environmental questions? Was it medical? Okay, Courtney thinks medical. Okay, I think so too. I think next class I'm going to try to bump 33 up into the medical module. That was the point of that. House cleaning things. I put on the discussion board I put on GroupMe some house cleaning items. I know that we were coming off of spring break last week, and so maybe that accounted for some of you kind of having trouble getting back into the grind, and there were some time management things, and some of you kind of got caught, and you requested some exemptions, and I gave none. We are well past that point, and it's not because I don't understand or empathize. I do. I know what it's like to be a collegiate student and have other things going on. I raised 2 kids and worked full-time in 3 jobs while going to school for my associates and then later for my bachelor's. I get it, and I empathize with you. You guys are awesome. You take on a lot of stuff. You're kicking butt and taking names out there, and I appreciate that. With that said, you got to find the way, the time management necessary to get this course done, and I know you will. So I'm not preaching at you as much as I'm reminding you. Whatever happened last week that got a couple of you caught, let's figure out this week and move right on forward. Discussion boards. If it takes me 2 weeks or 3 weeks to grade them, I will grade them. So it appears to me that some of you have kind of gotten the idea, well, maybe he's not grading these because I haven't seen them in 2 to 3 weeks. Oh, I am. And when they post, they will be forever. So you need to remember discussion posts. They are important. I don't give you busy work discussion posts. For example, last week's discussion post was on spine motion restriction. That is one of the hottest topics happening in EMS right now. To be boarding people or not to be boarding people, what criterion are we to be meeting, where's the national standard there? That is a big conversation that's happening right now in pre-hospital care. And as you go from one agency to another agency, there are very stark differences between a medical control physician's take on spine motion restriction of modern day versus another medical control physician. So I want you guys to be able to converse in that conversation. I want you to be well versed in the literature, not opinions or what this county is doing or what that county is doing, but where does the data stand? What studies do we have available to us to say this is where we should be getting our decision making? So that's why I post these discussion boards. And because they are important, I need you giving them your time. So as we've discussed all throughout the course, Every Sunday, stuff is due. I've been kind of lenient with the Mondays and allowing things to go over, but I'm going to stop that because now I'm finding that you people always need a Monday. And that's just kind of how life works. And that's not your fault. It's a human thing. I would be doing the same thing. You know, can I get Monday? Because I've gotten Mondays before. Well, here's the notice Mondays are gone. I'm not doing that anymore. We are going to keep to the week work like we're supposed to be. Everything is due by Sunday. Okay? You have a whole week to get this stuff done, a luxury that I would argue for most of your classes you don't have. So please find the time management necessary to get it done. I know you will. And so let's move on from that. I don't want to preach at you. I just kind of wanted to remind you. Sign-in sheets. Some of you have been really worried about sign-in sheets. You don't have to worry about sign-in sheets. If you aren't doing lecture assignments, then you need to worry because when I audit them, whenever I audit them, if I find out that you're past the 24-hour mark, you're past the 10% rule, you're out of here. And so if you are one of those people, then you do need to worry. But if you're everybody else and you have been submitting your time, your lecture assignment sheets via email, then you're fine. If you were on a lab day that I wasn't present, another instructor was, and they took a manual sheet, I have those sheets. They're stored. They're ready to be audited and added to the Google sign-in sheet, so you have nothing to worry about. If you have been present, you are fine. If you have not been present, you are not fine, and you should come talk to me. If I audit these sheets and I find out that you're past 24 hours, you're out of here. So, keep an eye on your time, but don't worry about the sheet if it's not accurate, but you know you were here. That's the point to that. If there's any question about that, give me a call. GroupMe attention. You guys know that I post a ton of information on GroupMe. I try hard to make sure it's nothing but meat and potatoes. I don't try to fluff it. I try to give you stuff you need, stuff that is coming to me during the week. Say a couple of you ask the same question. Well, then I'm going to go post it on GroupMe so that we can answer that for everyone at one time. So you got to pay attention to GroupMe. I feel like a couple of you ask me things that I recently addressed on GroupMe. So this is my reminder to you. It's not for you to disregard or to put on mute or to not pay attention to. You need to be watching GroupMe. As much as I put on there, it can get a little bit aggravating. Well, it needs to aggravate you because that's the most efficient way we have of communicating in the class. So please keep your eye on GroupMe. Okay? We have a lot tonight to finish up the trauma module. You'll be taking the trauma module exam not this week in lab, but next week in lab as we move on to the next module. So please be preparing for the module exam. Some of you really need a good grade. Most of you are great. Almost all of you are great, but some of you really need a good grade. As we have discussed before, when we're coming towards the end of a module, that is the prime time for you to be taking advantage of adaptive testing. Now that we have all the chapters under our belt, and theoretically you have read them one at a time as we progress through the module, it is prime time for you to start seeing where your knowledge base is via the adaptive testing. Don't walk up into next week's lab to take the trauma module exam if your adaptive test scores look like crap. You need to have worked on it. You need to have done the studying, okay? Also, make sure the level 4 reviews have been committed to memory. You know as well as I do that module exam questions tend to find themselves from the quizzes you've already taken. So looking at the level 4 reviews is of much importance. So please make sure that those are the things you have done to prepare for next week's module exam in lab. I will be at both labs this week. With that said, Wednesday will be intermittent in my presence because I have night vision goggle training. So I will go to the night vision goggle class. As soon as I finish that, I'll come back to you guys. And then I should be with you most of the night for Wednesday and for Thursday. We will do exactly what we did last week again this week. I encourage you to make sure that time is utilized appropriately. It's your time. We're getting to the point here where we're ready to go on checking some things off, making sure that you remember I have your final skills verification sheets You should be getting to the point of mastery for some of these skills. And when you feel that you have, come to me and say, please check me off for this. I go into my little sheets, I put you checked off for that skill, and that's one less skill that you have to do at the end of the class. Remember that whatever skills remain for you on your skills verification form at the end of the class, the last 2 weeks of this course, if you have things not checked off, it's go or no go time. You do not want to be in that predicament. Okay? So you have to use these free open skills practice nights wisely to get these skills checked off. I want to remind you that you are responsible for oxygen, via non-rebreather, bag valve mask station, supraglottic station, hemorrhage control station, lung bone and joint splinting station, trauma assessment, medical assessment, CPR station. Those are your skills stations that you have to do for the class, okay? We will do some assessments this week. We did not last week. That's because I want to dedicate our attention to those assessments. They tend to be an overall all-encompassing, so I like to give those our time and not split them up between individual skill stations. So we will see some assessments this week. We did not last week. Some of you were wondering, and that is the answer to that question. All right, let's get to, do we want to do 33 first? I'm fine with 33 first. Nah, I don't want to do 33 first. This week we will discuss chest injuries. This is a pretty big deal, and there is a visual component that I think you don't get from this reading material. And so I encourage you to go on to YouTube and take a look at some videos that are educating about specifically those that are geared towards EMS that give you a visual to pneumothorax and hemothorax. We've talked a lot about pneumothorax and hemothorax. However, we got to have that visual in order to understand why any penetrating trauma from neck to navel, 360 degrees, gets an occlusive bandage or potentially needs us to really pay attention to whether or not there is sucking presentation. If you see a bubbling wound that is small in nature and it is penetrating trauma, then you've got to cover that immediately. Maybe first you cover that with a gloved hand as you get your hyphen chest seal out of your bag or your occlusive bandage out of your bag and you put it on there. If you aren't very familiar with what an occlusive bandage is, you need to familiarize yourself. We've spent time on that in this class. Make sure you understand what a hyphen chest seal is. Make sure you understand what an occlusive bandage is and why we would use it. You can't forget the 360-degree neck to navel rule that is commonly on the psychomotor exam, and it's commonly on the computer-based testing as well. Okay, so that's kind of what this chapter is going to focus on. Obviously, we know how breathing should look. Obviously, we know the anatomy of breathing. When you know how something, when you know the anatomy of something and you know how that anatomy works, then you can understand how it breaks. And so it's pretty easy to understand the trauma that might be acquired, blunt speaking or penetrating speaking, when you consider the anatomy of the chest. So remember that blunt is not going into the skin. It is energy transferred. So we think about a baseball bat to the chest. Well, you've got that energy that keeps going. It doesn't just stop when the bat contacts the skin. That energy behind the bat keeps going into the chest and into the organs that are housed in that chest. So that is the thought that you need to put into chest trauma. Penetrating is kind of easy. It kind of speaks for itself. It's not easy because you don't know where the penetrating object went, whether that's a bullet, whether that's a knife. You don't actually know the trajectory of that. You don't actually know what it hit and what it didn't hit. But it is easier to understand penetrating trauma, where that exit wound is, potentially the entrance wound. We don't know which is which, so don't ever call things an entrance or an exit because you don't know. Okay, and it's easier to see that. But blunt trauma is more of a question mark, okay? So we're going to talk about the differences in those. We already discussed open chest wounds and sucking chest wounds. Those are the same thing. I want to remind you that if you were looking at the data, it says that any hole created in the chest that involves the peritoneum, remember the lining that goes around the chest that protects the heart and lungs, any hole greater than 1/3 the diameter of the chest results in a sucking chest wound. If it is that big or larger, then you will suck air into the chest with every breath. So I want to make that a lecture assignment question because I want it to have attention. How big of a hole do you need to have in the chest that penetrates the peritoneum that would create a sucking chest wound? And the answer is any hole greater than 1/3 the diameter of that person's trachea, which if you think about, that's not that big of a hole. It wouldn't take that big of a hole to cause that air to seep into the chest with every breath the patient is taking. So that is where you get the 1/3 the trachea talk, and that's where you get the 360 degrees neck to navel. Maybe we need an occlusive bandage talk. So pay attention to that and know that rule of thumb about the 1/3 or greater the size of the diameter of the trachea. Impaled objects we talked about last week. We're kind of reiterating that a little bit this week. So we'll talk about that again. Let me just confirm that everyone's still hearing me. Everyone's still hearing me? We're good? Okay. Lord knows I'm going to cry if the internet does that to me again. All right, so this is the stuff we're going to talk about. When we get to pneumos and hemos, it can get a little deep. What's open, what's closed, what's simple, what's tension. So we'll discuss that. We'll define those things. Hemothorax is the same. Pneumo means air and hemo means blood. So the same problem exists. We'll kind of define that a little bit more. We will talk about cardiac tamponade and Beck's triad. Beck's triad is the symptoms, the three primary symptoms we would see with cardiac tamponade that would make us say we should hurry. There's not a ton that you can do about cardiac tamponade except for treat the patient for shock and hurry. So it's important that you recognize it so that you can get the heck out of there. All right, so these are the things we're going to talk about. These are some defining terms for you, so make sure if you're reviewing the slides that you can define these terms by the time you're done reading the literature on the chapter. Obviously, the chest and the abdomen is a big deal. It accomplishes most of the central part of a person, so then it is susceptible to injury because there's a lot of it. You guys know what we do with the chest. We send blood round and round, and we take air in and out, and we move that air in around and round. So that's what we need to be able to do, and when we get chest trauma, then maybe we're not able to do that. So you got to understand how it's supposed to work in order to understand how it breaks. And so make sure you understand your chest anatomy. Here we go. We got our lungs, we've got our heart, our great vessels that are involved, and our diaphragm, which is responsible for creating that negative pull that inflates our lungs, makes us breathe. Hitting these great vessels is a big deal. And then let's not forget about secondary injury. When we review that whole concept, primary injury versus secondary injury, I don't got to shoot you in a great vessel for it to become a traumatic problem. I don't got to hit you with a baseball bat for it to become a problem. Let's think about the high-speed, immediate stop. Let's think head-on injury, motor vehicle accidents. When car A touches car B and your head flies forward and hits the steering wheel, that is a primary injury. That's a primary collision. But that isn't it. Your organs inside of you then begin flying forward, and they must then come to a stop. And if the large vessels or the heart or the aorta flies too far forward, too fast forward, it's going to take injury too. You could even rip those structures away from the anatomy that ties them down to the chest, which would result commonly in immediate death or death that quickly follows. So let's not forget the primary injury concept versus the secondary injury concept. Typically, primary is external, and typically secondary injuries are internal, like organ damage secondary to force. Okay, so that's how you kind of split it up in an easy way. External would typically be primary, internal would typically be secondary. Here's another look at that. So this is the lining, okay? You're looking at the lining behind the ribs that protects all of this. If you get air inside of the blue lining here, that is a pneumo. If you get blood or fluid inside of the lining and it's acting against the lungs, well, then that would be a hemo. So if you're only supposed to have enough room for the lungs to expand, any air, any blood that gets in that space is going to keep the lung from expanding. The more air, the more blood, the worse the pneumo, the worse the hemo, the worse the expansion. So the only thing you can do when you get air trapped in this space or when you get blood trapped in this space is to suck it out. And that's not a skill that you guys can do. You guys cannot decompress the chest. You don't have the ability to put a needle or a tube inside the chest wall and evacuate that air or evacuate that blood. So since you don't have that skill, you must call for ALS backup early. And you must recognize pneumos and hemos early. Just because something's not within your scope of practice to definitively treat does not mean you don't have to worry about it. In fact, you should worry about it more because how quickly you spot this, how fast you determine here is an emergency that I can't treat, let's get out of here, the better off your patient is. So you've got to be able to spot a pneumohemo. So let's talk about that real quick. Why don't you guys tell me what would be some symptoms of a pneumothorax? What would be some symptoms of hemothorax? They're roughly the same symptoms for us. Anybody? Anybody? Difficulty breathing? Absolutely. We can't. Air bubbles, yes, Max. I think Max is talking about subcutaneous emphysema. That's more associated with upper airway trauma like a trachea tear or a trachea trauma. That's not really going to be seen in a pneumohemo because it's lower, although it could happen, but that's not as common. Difficulty breathing is definitely common, right? Because the lungs aren't expanding. What else? Difficulty breathing. What physical signs are we going to see? Think about everything. Think about your primary. Think about your secondary. What signs are we going to see? You could be seeing some cyanosis, absolutely, because you're not exchanging oxygen. If you don't expand the lungs and you don't move air and blood round and round, you're not going to exchange oxygen. What about breath sounds? What are we going to see with breath sounds? If I have a pneumo on one side, what are we going to see with breath sounds? I mean, just think about it. If I've got a pneumo on my left side, that lung is not expanding. So then the breath sounds on that side would be absent. Maybe they're diminished. They're much less than the right side. If there is not expansion on that side, you're not going to hear good air movement in and out of that lung. And so absent breath sounds on one side is one of the most telltale signs of a pneumothorax. Okay? So absent breath sounds on one side is a big deal. You need to think about these signs and symptoms because the test questions are going to give you signs and symptoms and ask you what's wrong with the patient. So you've got to be able to answer that. The typical signs and symptoms of a pneumothorax is an obvious mechanism. So first of all, do you have anything that happened to the chest that would make you concerned for a pneumo or a hemo? Then you're going to have your physical signs and symptoms. Trouble breathing. It hurts to take a breath. Bilateral lung sounds are not present. You have good lung sounds on one side, but not good lung sounds on the other. That would be a good presentation for pneumo or hemo. Your SpO2 is going to become a pretty telltale sign. You even put the patient on high flow oxygen and the SpO2 is not moving. Well, that should be an obvious red flag for you. Because when we hyperoxygenate people, when we high flow oxygenate people, that is much greater than what they're used to. They're used to 21%. Now we're up to like 90 to 100% inhaled oxygen. Then I should see an immediate response in that SpO2. I should start seeing great things happen. Pink skin, better breathing. SpO2 goes much higher than 94%. In the pneumothorax patient, you don't see a big change in that SpO2. They were 91% on room air. You put them on a non-rebreather, and 10 minutes later, they're 92%. Well, that would be odd. It would be abnormal because you're high flow oxygenating the patient. So those are your telltale signs. Obvious mechanism, complains of trouble breathing, hurts to breathe, unilateral lung sounds. Lung sounds on one side are great. On the other side, they're horrible. SpO2 is not moving when you're high flow oxygenating the patient. And then we start looking at a bad pneumo. When you have a bad pneumo, the blood pressure starts to go really low and the heart rate starts going through the roof. Can anybody tell me, can anyone remember why significant pneumothorax, significant hemothorax causes low blood pressure? Anyone? No one can remember that? All right. Well, if you are building up air, so can everyone see my red marker in the hand on my screen? I'm over the lung. Can you see that?
Yes.
Okay, good. All right, so let's look at this side of the lung. Okay, this is the patient's left side. So on the left side, we're going to say that this peritoneum here starts filling up with air. The first thing it's going to do is collapse the left lung, right? It's going to be enough air over here to keep the left lung from expanding. But every time the patient breathes in, they suck a little more air into the lining, a little more air into the lining. And before you know it, it's like a balloon pushing the heart, the vena cava, the aorta, and eventually even the right lung all the way up against this right chest wall and smashing it. Not only are you unable to breathe, but now I've smashed the vessels, your aorta and your vena cava closed. I'm also squeezing the heart so it can't pump. That is why significant pneumothoraces, significant hemothorax, eventually causes low blood pressure. Once you start seeing a blood pressure change in a pneumothorax patient, if you do not evacuate that chest, they're going to die within minutes. Okay? So that's where we come to the terms. A simple pneumo is just a little bit of air in the space. They're mild dyspnea. They have a little bit of pain upon breathing. Their SpO2 is a little low, but you give them oxygen and they come right back to you. Okay, that's a simple pneumothorax. A tension pneumothorax is a deadly pneumothorax. When we say tension, we mean that you have created tension in the chest, yanking the trachea to the side and pushing all of that heart, great vessel, and lung anatomy and smashing it against the wall. So simple pneumothoraces don't tend to kill you. Tension pneumothorax tends to kill you. That's when you have enough air or enough blood to push the anatomy to the side, displace the trachea, and you can't get blood in the heart, you can't get blood out of the heart, and so what was initially a breathing problem is now a circulation problem. Does everyone understand what I just said to you? Raise your hand if you do. Okay then. So I ask you again, why does a tension pneumothorax kill people?
Because it squeezes and pushes your heart and your aorta towards the other side of the chest cavity, and therefore it can't pump.
That's correct. And then you've got the breathing problem too. If you took the lungs and you squeeze them, they can't expand. So the patient is going to literally start saying, I cannot breathe. Okay, so now I have a big breathing problem, and now I have a big circulation problem. And so the only thing to do would be to poke another hole in their chest and let that air flow out, rush out of their chest. Okay, that's a paramedic skill. That's a physician skill. So ALS backup is super important. Emergent transport is super important. Recognizing this has occurred, super important. Okay? So you need to be able to define the symptoms. You need to be able to define the treatments. You need to understand what a simple pneumo or hemo is versus a tension pneumo or hemo. And whether it's air or blood in that space, it doesn't matter. It's going to cause the same bad stuff to happen. Okay? So make sure you understand sucking chest wounds, understand what they will do to the heart and lungs, understand what the patient will present as, and what the definitive fix will be. Okay? Are there any questions about pneumothorax, simple or tension, or hemothorax, simple or tension? Remember to look for trachea, midline, tracheal displacement. Once we have a tension process, it's going to pull that trachea away from the middle of the throat. Now, I argued that that's a later sign. It's a really late sign. A lot of tracheal displacement is found post-mortem. The patient is dead already. So it's not super helpful to us. So we don't want to get to the point where they're yanking their trachea away from the midline of their throat and smashing the lung and heart anatomy and the great vessel anatomy against the chest wall. So we've got to recognize it and we've got to get it treated before that happens, okay? We already talked about this. You guys know about the intercostals, the muscles that go in between the ribs that help us breathe. Okay? You can look at the patient's chest and say, this patient is really having trouble breathing because I see every single rib they have. I see their sternum. I see their clavicle when they take a breath. That's not normal. That's a chest that's in distress. You guys already know how to breathe and how to look for breathing and the physiology of breathing. We've talked a lot about that. Make sure we're looking for seatbelt marks. I want to remind you, though, that seatbelt bruises are a late sign. It is not uncommon for us to not see seatbelt bruises. But after arrival at the emergency department for an hour, they now have this big, nasty seatbelt bruise. So don't take the fact that you don't see any bruising from seatbelt marks as they don't have any seatbelt bruises, because bruises are late. They don't come immediately. So we may not see them in our setting, and the emergency department may see them more in their setting. Okay? Whether something's open or closed, you guys already know what that is. Also, remember that blunt trauma can cause pneumothorax and hemothorax that you did not know was happening. Why? We break the ribs. The ribs are intact, right? Well, I take a big baseball bat and I smash the ribs and I actually break them a little bit to make sharp ends on the bones. Well, when the lung goes to expand, that sharp broken rib pokes the lung. Now the lung is leaking air with every breath, and that creates a pneumothorax. So don't forget that penetrating trauma is not the only way to get a pneumothorax. It's not the only way to get a hemothorax. Any big mechanism to the chest, whether it's penetrating or blunt, makes me concerned that the patient might be developing pneumothorax or hemothorax. Listen to those lung sounds. Look at that chest for bilateral chest rise and fall. Make sure the trachea is midline. Take a look at your SpO2. Take a look at your blood pressure. Make sure those things are normal. If they're not, get worried about whether or not the patient is bleeding into their chest wall or whether the patient has air stuck in that chest wall. Mark, do you have a question? We just hitting buttons? Okay. So think about that. They're gonna have pain at that site. They're gonna have pain when they take a big breath. That should be a big sign that worries you. Okay, listen to lung sounds. Hemoptysis. Does anybody remember what hemoptysis is? Coughing up blood. Coughing up blood, right? If you start poking holes in the chest, if you start leaking blood into the lungs, they're going to have that coughing mechanism and you're going to see a little bit of that blood. Okay, so that would be concerning for chest wall trauma, for lung trauma. Think about that. For lecture assignment, I want you to tell me what are the signs and symptoms of a pneumothorax and a hemothorax. And then I want you to tell me the difference between simple and tension. Why do I want you to know the difference? That's a lecture assignment question. All right, we already went through that. We've covered that significantly, so I hope you understand what a pneumo and hemo is and the difference between tension and simple, the difference between open and closed. This chart's really important. These are the deadly dozen for chest injuries. Let's go down them and look for things. Airway obstruction is pretty obvious. Bronchial disruption, if you actually have trauma to the bronchioles or the trachea for that matter. Diaphragmatic tear. The patient keeps saying, I can't breathe, I can't breathe, I can't breathe. Okay? And we have great lung sounds, but we're not getting any volume. Okay? The patient has bilateral low volume upon their breaths. You need to bag that patient. Okay? That patient needs to be intubated. You can't intubate them, but you can ventilate them, so we need to ventilate that patient. Eventually, they're not going to be able to breathe enough to get good oxygen. Remember your minute volume. If you have a diaphragmatic tear, that diaphragm's not working efficiently. Over time, that's going to make the breathing worse and worse and worse. And so think about minute volume. You're supposed to breathe 4 to 6, 4 to 8 liters per minute. If you're slowly losing liters per minute, eventually you will not have enough volume to cause good oxygenation. The way to fix that is to breathe for the patient. If the patient keeps saying, I can't breathe, I can't breathe, I can't breathe, and you're looking at shallow breathing, you've got clear bilateral lung sounds, well then pneumo's not your problem. Maybe you have a diaphragmatic tear. Breathe for the patient. If the patient says they can't breathe and you have shallow volume, breathe for the patient. You can ventilate patients who are conscious. You've got to do it by communicating with the patient. You've got to work with the patient's inspiration, but maybe they're not getting enough volume. Their stimulus to breathe is there. Their rate of breathing is there, but they can't get the volume because the diaphragm has been injured. So breathe for them. Esophageal injury is pretty obvious. Open pneumothorax is that 1/3 greater the diameter of the trachea that we talked about. That's when the chest is open and bubbling. You see it. That's very dangerous, very bad. That means
for this one because I'm going to be down.
Shy, you okay? You keyed up your button there. Make sure you guys are able to be paying attention. Thanks, Shy. Welcome back. Open pneumothorax is that big, nasty, bubbling one. That is when it's big enough, guys, to cause death in a few breaths. You have a big enough hole in the chest wall that when you breathe, you're sucking large amounts of air into the peritoneal space. It's going to quickly overcome the lung. It's going to quickly start smashing the heart and great vessels and that good lung to the side of the wall of the lungs, to the side of the wall of the chest. And eventually, in 5, 10, 15 breaths, you can't breathe anymore. And you have a blood pressure that's absent. The patient is going to die very quickly. That chest needs to be evacuated. You need a medic. You need a medic who can poke a hole in that chest and get the air out of it. And then we cover up that hole so that it can no longer do that damage. Tension pneumothorax is the same thing, basically. You just don't have this big gaping hole in the side of the chest. Massive hemothorax, bunch of blood in the space causing the same thing. Flailed chest. We need to talk about flailed chest. Flailed chest is defined as 2 or 3 or more ribs broken in multiple places. Now, the exact verbiage of that gets defined by whichever book you're looking at the moment. But basically, you think about multiple ribs broken in multiple places. They lose their rigidity. They lose that ability to get good rise and fall out of the chest. So basically what you start seeing in the chest is one side's rising and one side's not rising. I told you guys to take a look at some flail chest videos before, and that will be a part of your discussion assignment this week. You will be looking at pneumo videos, hemo videos, and flail chest videos this week so that you have a visual of what those things look like. the treatment, I'm going to give it to you, Courtney. So you can just, when you go do the discussion this week, you'll be good to go. Okay? The treatment for flail chest is the same as for diaphragmatic injury. They're not getting good volume on that side because the chest wall is not working appropriately to cause expansion. So then breathe for them, right? The treatment for a flail chest, you look at their chest and they're seesaw breathing. The right side of the chest comes up, the left side of the chest goes down. The right side of the chest comes up, the left side of the chest goes down. It's not working. So that would be the need for you to positive pressure ventilate the patient. So if I quickly go over to YouTube real fast, I'll just screen share with you guys. It doesn't take much to find some really cool videos on flail chests, and you can see how quickly it might cause the patient to deteriorate. And you can solve that deterioration by positive pressure ventilation. All right, let me find a real one here. All right, let's look at this guy real quick. All right, you can see that this side of the chest is not looking like this side of the chest. There's gross external damage there, and the chest isn't expanding very well. It looks like one side is rising well and one side is not. Okay, let's get an even more obvious one. These are not quite as grossly obvious as some of the others. Let's look at this guy. Do you see that sucking in here? That's not supposed to happen, right? Look at this side. This side is all unilateral, and then one side is sucking in. Look at this sucking in here. There's breaking of the ribs right there, okay? None of these are as good as this bad boy. Look at that. That's the nipple right there, folks. That is extreme rib damage right there. Now the breathing is trying to happen, but there's no ribs to breathe against. So you have a flail chest. This guy's in a lot of distress. You should be breathing for him. Obviously, he's going to be breathing fast. So you've got to really work with that patient's breathing to be effective. Okay? So flail chest is when we break enough ribs that the chest expansion is ineffective. Okay? I'll let you look at the definition in the book, but I want you to have a good visual. The treatment for flail is to ventilate the patient. Why is it stupid to ventilate a pneumothorax? Why does positive pressure ventilation cause death in a pneumothorax patient? Because some of these, the answer is breathe for them. A pneumothorax patient is going to say, I can't breathe, I can't breathe, I can't breathe. Why should you try your best not to ventilate that patient? Anybody?
Isn't it just going to push more air into the space instead of pushing everything
100%,
against the
Dominique.
heart?
That is beautiful wording. 100%. If the problem is that every time they go to breathe, they suck more air into the space outside of the lungs, and it's basically blowing up a balloon against the lung, against the heart, against the great vessels, if you go shoving more air down there, it's going to be faster. You're going to speed up the process. So you would not want to get into a situation where you have to ventilate a pneumothorax patient. Now, eventually you might have to, because say that you don't have a paramedic that's close enough to you. Say you don't have a hospital that's close enough to you. You might have to eventually, if the patient gets to a point where they can't breathe, not even at all, then you've got to try to ventilate them. So my question to you is, by that time, will you be able to ventilate them? And the answer is no. You will not get the breath to go in because there is so much air collapsing the lungs that when you try to ventilate, it will not let the lungs expand. That's why they die. Okay? So if you're getting a very non-compliant BVM ventilation, it is very hard to squeeze that bag. You're trying to squeeze that bag and it's just not able to be squeezed. That patient is, if not already, going to die. very fast. We need to poke a hole in that patient's chest and let the air out so that the lungs can expand. If what I'm saying to you just is not visible, you just can't see the physiology, you need to speak up, because this is a primary conversation of this entire module. Okay? Let's move on to cardiac tamponade. Cardiac tamponade occurs when you put fluid, air, pus, blood in between the sac around the heart and the heart itself, the pericardial sac. I want to remind you that all of your organs have a lining around them. In between the organ and the lining is just a little bit of fluid that makes the mechanical organ able to do its job. It's kind of like a lubricant, let's just say. Okay? But what if you got hit in the chest with a baseball bat and a little bit of the vessels around the heart have started bleeding? And now they're bleeding into this lining around the heart. Well, that lining is only so big. It can't expand. It doesn't have room to expand. So if you bled enough into the space between the cardiac lining and the heart itself, you would eventually squeeze the heart so bad that it couldn't beat. And if it doesn't beat, you don't get blood out of it, right? So cardiac tamponade is exactly that. The word tamponade means to squeeze until it doesn't work. If you tamponade the heart, you have squeezed it until it cannot squeeze blood out. The patient would die. You need to remember Beck's triad. Beck's triad is the symptoms you would see, the signs that you would see if the patient were experiencing cardiac tamponade. Beck's triad includes muffled heart tones. I told you in secondary assessment I wanted you to listen to heart tones, and I only wanted you to know that they were clear and distinct. Clear and distinct, that they didn't sound muffled, that they didn't sound far away, that they didn't sound like they were underwater. That is what we're listening for in the trauma patient that has a chest mechanism. I'm looking at the chest of the patient, and they've clearly, visibly been hit, struck, traumatically exposed in their chest. I would look for Beck's triad now. Listen to the heart tones. Do they sound muffled? Okay. If they do sound muffled, then I'm worried that there is space between the lining of the heart and the heart itself. When you create a big space between that, it starts sounding like the tones are far away. That lub-dub, 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 lub-dub starts to sound very far away. It starts to sound covered up. So the first component of Beck's triad is muffled heart tones. The next component of Beck's triad is JVD, also present in significant pneumothorax and hemothorax. Why? We said that any time the natural return of blood flow from the brain is resisted by the chest, you will get JVD. It makes sense that if there's a bunch of air pressure or blood pressure squeezing against the heart, squeezing against the lungs, that you would engorge the neck veins. So JVD is a huge finding in a patient with an obvious chest mechanism. The last is low blood pressure. Obviously, if we're tamponading the heart, you're squeezing it until it cannot function. It's no longer getting blood out. So then the blood pressure is going to steadily decline. Okay? So Beck's triads typically understood to be muffled heart tones, JVD, and low blood pressure. Now the book will talk about pulse pressure in this conversation, which is easily understood. Narrowing or widening of the pulse pressure is easily understood. However, the result of that is going to be low blood pressure. You need to know Beck's triad, and you need to know when to look for Beck's triad. I would look for Beck's triad if I had an obvious chest mechanism. If I'm looking at a heart rate that's 160 and I'm looking at a baseball bat bruise to the center of the chest, you need to look for JVD. You need to look for muffled heart tones, and you need to understand that the low blood pressure you're seeing on the monitor means that the patient is bleeding into the sac around their heart, and you should run, because the only thing that's going to save them is surgery or poking a needle, something called a cardiac centesis, a pericardial centesis. We're going to poke a long needle into that sac and drain the blood out. That would stop this whole process and allow the patient to start beating correctly again, pushing the right amount of blood out again. Any questions about cardiac tamponade? Again, a pericardial centesis is a paramedic skill. It is a physician skill. So ALS backup is really important here. Going to the closest hospital is really important here. Even if a hospital is not a trauma center, an emergency room has to have the most life-saving stuff available to the patient. Blood products, chest tubes, pericardial centeses. That doctor probably doesn't want to do those things because they don't do that every day, and that's understandable, but they have to. So if you find out that you went to a significant mechanism of injury at Midland Parkway and Dorchester Road, or Ladson Road and Dorchester Road, you're right by Somerville Medical Center. You say to yourself, well, gosh, Somerville's not a trauma center. If your patient has an ABC emergency, you can't get them to breathe, you can't get them to perfuse, then you have to go to the closest hospital possible. The doctors at Somerville can intubate your patient. The doctors at Somerville can give your patient blood. The doctors at Somerville can do chest tubes. The doctors at Somerville can do that big long needle into the heart sac and drain out that blood so that your patient doesn't die in the next 5, 10, 15 minutes. After they save their life in that regard, yes, we're going to transfer the patient. That's what your helicopters do every day. But they wouldn't make it there if you don't go to the closest thing, smoking. So yes, we want a trauma center for trauma patients. But you got to understand that sometimes you won't make it to a trauma center. And that every emergency room is required to be able to treat these most life-threatening things. Any questions about that? All right, let's take a 5-minute break. 7:05, we will come back, okay? 7:05 sharp.
You are now muted. You are now unmuted.
All right, kids, welcome back. All right, continuing with our deadly dozen, we've covered up to cardiac tamponade. Let's move on to 10, 11, and 12. For thoracic aortic dissection, most of these, this is a high mortality. So let's think about secondary injury pattern. Primary injury, head hits the steering wheel, big gash. Secondary injury, the organs fly forward and they sustain trauma because of their moving forward at a high energy. That would be a thoracic aortic dissection. So think about two things here. So the aorta is connected to the chest via a little appendage, a little ligament. If you rip that away from the chest wall, the aorta will immediately begin bleeding heavily into the chest. The patients tend to die really quickly from that. You walk up to the car, there's not a bunch of gross external trauma, but the patient is white as a ghost, not breathing, has no pulse. The paramedic tells you that they're in asystole on the monitor. So they have no heartbeat, no rhythm. Why did they die so fast? It's not crazy to think that they might have had an aortic dissection where the aorta basically bursts or tears in the chest due to high energy forces. If you ever hear anybody say 55 miles per hour, stay alive, 55, stay alive, well, that's where we got that. You can wear all the seatbelts you want, you can have all the airbags you want, but there is a point in which, now that point is variant based on the physics involved, but there's a point at which, no matter how much protective equipment you have on you, the organs don't have airbags. The organs don't have any protection to keep them from moving about inside of your body. And so if you come to an abrupt stop because of a head-on collision, you are going to sustain intra-abdominal, intrathoracic aortic trauma, and there's nothing we can do about that. You are going to die. We know that once you start getting above 55 miles per hour, that's when that chance starts looking pretty rough, depending on the conditions, the variables, the physics involved. Okay? So that's what 10 is talking about. 11 and 12. 11 and 12 goes mostly to the concept of blunt trauma. Okay, you get hit in the chest with a 2x4. Maybe you fall off the roof and you hit your chest, but you didn't break any ribs. You didn't collapse your lung. You didn't create a space between your lung and your heart and your pericardial lining. None of that stuff happened, but you bruised the heart itself, or you bruised the lung itself. Remember that a contusion is a bruise. Well, that's a real physical thing that's happening, a bruise. So imagine what would occur if you ruptured the little tiny bitty little vessels in a specific space of the heart or lungs, and that little bleeding kind of spread about the size of a quarter, maybe a $50, and then maybe even, a dollar bill. What would that do to the actual function of the heart or lungs? That's what we're talking about when we think about cardiac and lung contusions. So here's what the book wants you to know, and here's what you need to think about. We don't tend to see life-threatening things happen to heart bruises and lung bruises in our setting. The paramedics and the EMTs are not going to see the most ugly things that will happen to a person if they create a big bruise on their heart or lungs. You tend to start seeing those symptoms 24 hours, 48 hours, 78 hours, 72 hours after the occurrence of the event. So most likely, this will be managed in the ICU setting. If this is big enough, here's what will happen. The fluid will fill the lungs. So if it's a pulmonary contusion, they can go into flash pulmonary edema. If you get a big old bruise on the lungs and it's not doing its job very well, it's not expanding very well, you can actually have flash pulmonary edema where the lungs fill up with fluid and the patient obviously cannot breathe. Not very common from a pulmonary contusion standpoint in the pre-hospital setting. In the heart's regard, big old bruise on the heart, they can go into arrhythmia. So when we see a big ugly bruise on the chest and everything else is checking out, everything else looks good, you'll see us put the cardiac pads on the patient. You're like, Well, are we going to shock them? No, we're not. But if they are to go into an arrhythmia, we are. Because it will save their life. The most common deadly thing from a cardiac bruise, secondary to trauma, is that you'll go into an arrhythmia. The big problem with pulmonary contusion is that you start getting fluid in the lungs, and the patient can go into what we call ARDS, acute respiratory distress syndrome. Again, 11 and 12 don't tend to kill people in the pre-hospital setting. They tend to kill people 24 hours later, 48 hours later, okay? Or at least become emergencies 24 hours later, 48 hours later. So just remember that just because you didn't create a hole, stop it. Yeah, all right. Stop. Just because you didn't create a hole, or just because you did not injure the heart or lungs in a way that's super obvious to us in the pre-hospital setting, doesn't mean that patient might not encounter emergencies down the road. So then, all of that to say this: be careful letting people refuse when they've had trauma, because you don't know if these conditions that tend to worsen in 24 hours tend to worsen in 48 hours exist. So if there's a large mechanism of injury, the vehicle is torn all to hell, they fell off the roof, but they look okay, you need to tell them why they may not be okay. There may be things happening to you that I cannot see on the outside of you. It may look like you fared well, but there might be internal injuries we can't see with the naked eye. And because of that, at a minimum, you should be evaluated at the emergency room, where we can do some radiological imaging to determine whether there is or isn't an emergency. So that's the deadly dozen. That's the most of what we need to talk about in the cardiac chapter. I'm going to zoom through and make sure there's nothing else that I need to hit on. And we're going to move on to the next chapter. We talked extensively about this, and this, and this, and this. This is a slide that we should discuss. All of this bruising from the nipple line up is very common for traumatic asphyxia. If you break the trachea, you're going to get that subcutaneous emphysema that bubbles underneath the skin, that feels like Rice Krispie treats underneath the skin, and they're going to have a nipple line up blue-purple presentation, because that's where you immediately stopped oxygenating. Okay, so this picture is traumatic asphyxia. You're going to see some questions that talk to you about a patient suddenly dies. A patient is blue or purple from the nipple line up. What do you think happened? Their skin is blowing up. There's air trapped underneath their skin. What do you think has happened? Well, they must have poked a hole in their trachea, or fractured their trachea, or fractured the bronchioles, and now air is escaping and not expanding the lungs. So when they take a breath, instead of it making the lungs rise and fall, that air is escaping out into the skin. You don't oxygenate and you die very quickly. Okay? That's traumatic asphyxia. Those patients tend to die pretty quickly. In review, when the chest impacts the steering wheel during the motor vehicle crash, rapid deceleration, resulting in injury that kills 1/3 of patients, usually within seconds. Obviously, we're talking about aortic shearing. We discussed what would happen if the aorta was not able to slow down in enough time and rips itself away from the chest wall. You would immediately rupture it, and it would begin to bleed to the chest. The patient would die. And the answer is B. Signs and symptoms of a chest injury include all the following except. Please speak up. Speak up. This question requires you to know some of your medical terminology. Yeah, hemoptysis is coughing up blood, and we know that that is a sign of chest trauma because coughing comes from the lungs. So then that's chest. Hematemesis is throwing up blood. Emesis means vomit and hema means blood. So that's not typical of chest trauma. So then B is why I would say that's out. Asymmetrical chest movement is common for pneumo. It's common for flail chest. And pain with breathing is common for all those things. So B is the one that's out. During your assessment of a patient who was stabbed, you see an open wound to the left anterior chest. Your most immediate action should be. So you have an opened chest wound. D is correct. Cover the wound with an occlusive dressing. If you are doing a trauma assessment in the classroom, more importantly, if you're doing a trauma assessment in the field, you must immediately recognize open chest wounds, bubbling chest wounds, penetrating wounds to the chest as a life threat and cover them immediately. You cannot go on to ABCs until you have treated all life threats. Significant bleeding is a life threat. Sucking chest wound is a life threat. So you have to treat those before you go on to airway, breathing, circulation. No one cares about airway and breathing if they're going to be out of blood volume in 60 seconds. You've got to fix life threats or the rest of it doesn't matter. When caring for a patient with signs of pneumothorax, your most immediate concern should be come on, people. I'm worried about your ability to breathe, okay? You're not losing blood, so A is out. B might be true, but it's less important right now. It's saying that it's a pneumothorax, not a hemothorax. So then B is out. Associated heart injury. That's not important here. We're talking about a pneumothorax. And so I'm worried about your inability to breathe. C is the answer. What purpose does a one-way flutter valve, also known as a occlusive bandage, serve when used on a patient with open pneumo? So what is that one-way thing? How's that working? It's wanting you to understand the physiology there. It only prevents air from entering. That is correct. So air can move out, but air cannot get back in. We would want trapped air in the chest to be able to get out, but we don't want any more air in. Evacuating that trapped air is a good thing. It will allow the lungs to expand again. That is what we're going to do as paramedics. I'm going to poke a hole in the chest. I'm going to put in a chest tube or a needle or a finger to open the chest wall and let the air come out. That's a good thing. So a one-way chest seal, like a hyphen chest seal, or an occlusive bandage taped on three sides, the idea is keep air from going in, but if some air can come out, let's let that air come out. So C is correct. Nope, I might have read too fast. B, it allows the release of trapped air. Yes. So B and that's kind of a-hole-ish. B and C are saying the same thing, but B is talking more towards the question. So the one-way system allows trapped air to be released. So we understand why. We were just reading really fast there. Ariana, 5 points off. You led me astray. I'm just kidding. So B and C are kind of saying the same thing. I hope you can see why they're saying the same thing and why B, yes, I agree, is a better answer. The most important part is getting air out of the chest in the regards to a one-way system here. Signs of cardiac tamponade include all of the following except, this is Beck's triad. Which one of these is not Beck's triad? Yeah, we know it's not going to be a collapsed jugular vein. It's going to be engorged jugular veins because the pressure of the heart being squeezed resists the flow of blood returning from the brain. So it won't be collapsed veins, it'll be JVD. So 6C is not a part of Beck's triad. We know that Beck's triad is muffled heart tones, JVD, and low blood pressure. Now, here we see it talking about the heart's inability to contract and relax. As a result, the systolic blood pressure decreases. So that's your low blood pressure, and diastolic blood pressure increases, which is narrowing pulse pressure. I told you that it's going to talk about both. Yes, the blood pressure is low, but how is that actually being accomplished? You're suppressing the left ventricular ejection, so then systolic goes down. But as soon as the systolic relaxes, you have all this squeezing pressure that's going to shoot the diastolic pressure up. And so then that is a narrowing pulse pressure. I'd rather you focus on low blood pressure as being significant, although narrowing pulse pressure is very diagnostic. Once you start seeing the systolic climb on top of the diastolic, your patient is going to die. We talked about that. So we do have a triad that has widening pulse pressure, okay? And we do have a triad that has narrowing pulse pressure. So you got to remember the difference, okay? Because maybe it doesn't tell you on your particular question that it's low blood pressure. Maybe it says narrowing pulse pressure, but one of the options is widening pulse pressure. You got to know the difference, okay? Can anyone tell me the triad that has widening pulse pressure as a component? We'll make that a lecture assignment. Beck's triad has narrowing pulse pressure. Which triad has a widening pulse pressure? Yeah, Cushing's triad, which we remember is from brain insults. We've got this crazy increasing intracranial pressure that's squeezing the brainstem down through the foramen magnum. That's going to cause a widening pulse pressure. We're going to see that systolic climb through the roof, and that diastolic is going to die off. So initially we see this really high blood pressure that eventually gets low and looks really horrible, but initially it's really, really high. Okay, so know the difference between the narrowing and know the difference between the widening. And this is a great answer here, a rationale as to helping you understand that physiology of why it narrows. Why does that systolic drop so drastically and that diastolic climb up so high? This is a great explanation of why. Severe compression of the chest. You suspect traumatic asphyxia, hemorrhage into the sclera, and which other sign? We remember that the sclera is the white of your eye. If you squeeze the chest, it's going to burst the vessels in your eye, causing hemorrhage in your sclera. What else would we see? We saw a slide. Yeah, you'd get that big purple nipple line up thing going on with the face and the neck. That's traumatic asphyxia all day long. We also see that, guys, in pulmonary embolus, but that's not a trauma thing, right? So if this is a no trauma call and you see nipple line up is blue, that's probably indicative of a pulmonary embolus or an occlusive shock. Versus in the traumatic patient, it's indicative of traumatic asphyxia. A 14-year-old baseball player hit in the chest with a line drive. He's in cardiac arrest. Explain why. I'm glad this question got asked because I didn't really touch on it, but I think you can answer it by reading here. All right, so you guys are going with A, and I applaud that because we talked about myocardial contusion. But I told you that myocardial contusion starts presenting symptomologies in the 24-hour, 48-hour mark. So that's not going to work here because it says this guy got hit in the chest and drops immediately. The answer is commotio cordis. Let me explain why. Yes, he might have a myocardial contusion, but myocardial contusions become symptomatic in 24 hours, so then that won't work. Commotio cordis is when you get struck, typically in the left ventricle, at just the right time to interrupt the electrical rhythm of the heart, and you drop dead. if you shock that person immediately, you're going to correct the problem and they're going to live and not die, typically speaking. Statistically speaking, the faster you shock them, the more likely we are to save this person. That is commotio cordis, or something we call R on T phenomenon. So when you think of commotio cordis, this is that Japanese karate technique where you strike a person in the chest and they drop dead. That's what you're trying to achieve in that Japanese karate technique. That is commotio cordis. We see this in baseball players. We see this in patients playing racquetball. We see this in patients who have those machines that are shooting the tennis balls at them. If you get struck dead center in the chest at just the right time, you'll drop dead from an arrhythmia. That's called commotio cordis. So the answer here, because it is acute and sudden and immediate, is C, not A. Paradoxical chest movement. Paradoxical means seesaw. One side up, one side down. One side up, one side down. What do you think? Paradoxical means seesaw breathing. Flailed chest. Very good. Flailed chest. And we remember that flailed chest is when the ribs have been broken enough that they don't cause good expansion on that side. And the answer to that is positive pressure ventilation. 40-year-old man, unrestrained driver, hits the tree, high rates of speed, strikes the steering wheel with the chest, large bruise over the sternum, irregular heart rate. You're most concerned with what? My caution to you for this question is don't read into this. All right, let's go in through it. Could he have injury to the myocardium? Yes, I am worried about him having a myocardial contusion because his heart rate is now irregular and fast, right? Has a collapsed lung and severe hypoxia. It doesn't say a word about trouble breathing or unilateral lung sounds or JVD, so that's out. You can't read into the question. So B is out. Has extensive bleeding into the pericardial sac. Again, it doesn't say anything about Beck's triad, doesn't say anything about JVD, doesn't say anything about blood pressure, doesn't say anything about muffled heart tones. So you can't read into it. So C is out. D is at extreme high risk of VFib. Well, we do know that if you have a cardiac contusion, you could go into an arrhythmia that's lethal. So A and D is definitely what I'm choosing between. But I'm going to choose A because it's global. It is not assuming. VFib specifically, I don't know. Arrhythmia would have been a better word. But in our setting, I'm more concerned that he injured the myocardium, and I'm going to keep an eye on it, knowing that it might progress to D later. So I'm going to say A for now because it is most global. It is most correct. It can't be disputed as well, I think, as D. And so I'm going to hope that I'm right. It's A or D. And they went with A, thank God. So D could be the resulting rhythm, but it could be other rhythms too. And so that's why I think D was too specific. D was too assuming. I think that A would be harder to rebuttal than D. I hope you processed that with me and you understood why I went where I went. All right, let's take a 5-minute break at 7:30. So let's come back at 7:35. We'll start the next chapter. 7:35.
You are now muted. You are now unmuted.
Okay, moving on. Go ahead and put your hands up for me, please, and make sure everybody's back here. Only 8 people. 2 more people. Sarah, Shy, y'all still with me? Thank you. Shy, where you at? Shy, are you still with us? Are you playing hooky? Have to see. Call on Shy again in a couple minutes. All right, let's move on to abdominal and genitourinary. We're going to zoom through this one. I'll let you do the reading. This is more of a reading chapter. We'll discuss some more terms. Obviously, we're still looking at blunt versus penetrating trauma. Evisceration, we remember, is when the abdominal contents come out. We've talked about the fact that that's not normally as much of an injury as it looks. It's kind of distracting. We remember that the treatment for evisceration is keep it moist, keep it warm, keep it sealed like an occlusive bandage. We talked about saran wrap being such a good option here if you have saran wrap. A lot of places don't, and so maybe you don't use saran wrap, but if you did have saran wrap, you could do that. If you don't, irrigate the area with a solution that's sterile, like normal saline, maybe sterile water. Hopefully that'll be a warm fluid. Keep the tissue warm, keep it sterile, keep it moist, and keep it occluded. Don't let that potentially suck air into the chest. So that's an evisceration. We remember that. Impaled objects, we remember that we are to secure them with bulky dressings. That is the treatment. Secure impaled objects with bulky dressings. Stabilize them. Keep them from moving. Don't let them further injure whatever they have contacted on the inside of the patient. We don't remove impaled objects unless it's necessary for CPR. We discussed that removing impaled objects allows any bleeding that was controlled by the object itself to bleed again. So taking out an impaled object tends to result in exsanguination. We don't do that. So secure it in place with a big, bulky, stabilizing dressing. You need to remember how solid organs and hollow organs feel pain. So typically organs feel pain in a dull sense, okay? Organ pain is dull. You got to know which organs are solid and which ones are hollow. Hollow organs tend to hold things like the bladder holds urine, for example. Your solid organs that matter are the spleen and the liver, the kidneys as well. These solid organs do not rupture, they lacerate. And when you lacerate, you cause a lot of bleeding. Hollow organs that rupture is bad. They're a big infection risk, but they're probably not going to kill you right now. When you have a solid organ that gets injured by trauma, whether that's penetrating or blunt, you have laceration bleeding. And so then we risk losing life from hemorrhage. You tend to really worry about the spleen and the liver. Those are the 2 organs you got to pay much attention to. The liver is on the right upper quadrant, taking up a lot of space, and the spleen is smaller in the left upper quadrant. You can live without your spleen. You don't tend to live well without your liver, although you can cut pieces and parts of the liver out and the patient will do fine. So those are the 2 big solid organs that tend to kill people in the abdominal chapter. You got to take some attention to that. We remember that palpation of the abdominal space, when we think about abdomen and trauma, we think about whether the belly is soft, non-tender, and whether it's normal in temperature. If it's not, then we call that a hot belly. So let's say that you've got big obvious bruising to the belly and you feel that belly and it's rigid. It's very tough. It's very hard. That would be very concerning for intra-abdominal bleeding. I'm worried about the liver. I'm worried about the spleen lacerating and causing bleeding inside of that belly. So hot belly is the thought of abdominal chapter trauma lessons. When you think about abdominal trauma, you think about hot bellies. Hot belly being a term that we just kind of give patients who we think have internal belly bleeding. That's a big deal. It's a big life threat, and the only thing that's going to solve it is getting to the operating room. So that is why we remember the 10-minute on-scene time for trauma. I want to reiterate to you again that you should not be on scene with trauma patients longer than 10 minutes unless you are trying to manage a life threat, unless you are trying to manage ABCs and spine, and you can. You have the equipment, you have the resources necessary to manage that, then that might be a reason you are on scene a little longer than 10 minutes, but you should always shoot for 10 minutes. Why? You want that patient on the operating room table as soon as possible. So we don't delay scene time to get IVs, to get medications, to get this, to get that. Get out of there. Get as much things done on the way to the hospital as you possibly can get done and get out of there. Okay? So you shouldn't be seeing a whole bunch of high-level procedures or delicate things done on scene unless they're necessary to sustain life. The pelvis. The pelvis is a big deal. I'm going to post something to this week's discussion board about the pelvis, just to give you a little bit of information about pelvis trauma. Pelvis trauma is a life threat. The pelvis being unstable indicates that the large vessels running through it potentially have been injured to the point that they're bleeding. 90%, that's a statistic that comes from a study, it's not something I made up, 90% of pelvic bleeding is venous in nature. That's a good thing for us because venous bleeding is easier to stop than aortic or arterial bleeding. So what do we do with an unstable pelvis? We remember that to assess the pelvis in a trauma patient, you push it down gently and you push it in gently. Push it down gently, you push it in gently. If it gives way, it's not stable, and I have to worry if the vessels, the big vein and artery that runs through the pelvis, has been insulted or injured. 90% of the patients who are actually having intrapelvic bleeding, it is venous bleeding. And so if we bind the pelvis, we have a good chance of 1, stabilizing it, 2, helping with pain control, and 3, causing enough pressure from the binding to stop the venous bleeding. Pelvic bleeding is a hot topic right now, and it is so because it's missed often. If the patient has large level pain associated with your pelvic assessment, bind it. If there is instability, bind it. You should be checking pelvises in the primary because they are a life threat. The longer it's not bound by either a commercial device or even a sheet, the longer that venous bleeding, likely to be venous bleeding, goes on. You can lose 2 liters of blood volume in a pelvis. You only have about 5 liters of blood in your body. It only takes half a liter to cause symptomatic presentation, where the patient is starting to show you that they are in shock. Let's go over those numbers again. You have about 5.5 to 6 liters of blood in your whole body. It takes about 500 cc's of loss before you start getting anxious, tachypnic, tachycardic, changes in skin. And it takes 2 liters of blood volume to fill up the pelvis. That's a lot of potential bleeding and a very great risk for life threat. Bind pelvises that are unstable. Huge deal. You can easily articulate that the pelvis should be included in your primary assessment because it is a life threat. In fact, if you are looking at the trauma assessment sheet right now that we've included in this case, this class, there is a star in the secondary exam of the pelvis. And if you look at the top of the sheet, it says that anything with a star may be done in the primary if articulated as a life threat. You can articulate easily that an unstable pelvis with venous bleeding, 90% of them, requires binding in order to stop that bleeding. Bleeding control takes place in the primary, not only external bleeding. You can't stop abdominal bleeding, so then there's nothing to do but run. You can't stop a lot of other intra-space bleeding. You can do something about unstable pelvises, superior pain to pelvic palpation, where the patient screams out in pain because you touch their pelvis. That pelvis should be bound. And guess what? If we get to the hospital and we find out that the pelvis is fine, nothing's been lost. To bind a pelvis that isn't broken is risk of nothing. To not bind a pelvis that ends up being a particular bleed, that is very risky to the patient. So we should err on the side of binding pelvises. If you were a trauma surgeon here in this lecture right now, you'd be like, I don't know about that, Justin, but here's the deal. They don't work in our environment. There is no data, there is no study to show that binding pelvises causes harm, provided that you didn't delay emergent transport or other big procedures needed to sustain life, which they tend to not. Pelvic binders are very quick. They're very commercial. They're easily done. It could even be a sheet put around the waist of the patient tied in a knot. Just that simple. It doesn't take anything to bind a pelvis. That's my story on pelvic trauma. It's a big topic right now. It's missed an awful lot in the field. And the reason that we're so sad about missing it is the fact that 90% of that is venous bleeding. We could have stopped that bleeding or at least slowed it down, saving the life of our patient. So please think about pelvic trauma a lot. Check the pelvis. Don't be afraid to include it in your primary exam. That is completely acceptable and easily able to be articulated as a potential life threat. And if I were you, when I was doing my primary assessment, I would palpate the pelvis, gentle push in, gentle push down, and I would say out loud that I was doing so because a pelvic fracture is a potential life threat. All right? Moving on from that. You guys know this already. I'm going to let you read that. I'm not going to read for you. We talked about the organs that matter a ton. We talked about the difference between solid organ and a hollow organ, and that we worry about solid organs because they lacerate and bleed a lot. Don't forget about the kidneys. They're in that retroperitoneal space. That retroperitoneal space, which means they get to bleeding and they get to hemorrhaging emergently in a confined space that's harder to detect. So you got to think about it. If the patient's complaining of flank pain, flank mean the right, left rib area, think about those kidneys. Did we get a laceration to a kidney? Maybe even the artery flow, the arterial perfusion of the kidney can become insulted. And bleeding into the retroperitoneal space tends to cause flank pain, tends to cause bruising, specific types of bruising around the abdomen. When you read this chapter, there are a couple of talks about specific kinds of bruising, like bruising around the umbilical cord. That means something, and it's called something. I encourage you, when you read this chapter, to look at what that's called and what causes it. You're going to see test questions that say, you find peri-umbilical bruising. What sign is that? What sign is this causing what? So not only do I need to know the sign, I need to know which injury that sign is correlated with. I'm going to let you read that. I'm not going to do it for you. We already talked about evisceration. That's a big part of this chapter. In the sake of time, I am moving through to only the most important stuff. Remember, DCAP BTLS from head to toe. Your secondary exam in the psychomotor station, but even more importantly, in actual practice, you need to feel, palpate, inspect from head to toe, putting your fingers on every single spot. For D, cap, BTLS, deformities, contusions and crepitus, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. I would not be surprised if that showed up on an acronym quiz this week. I talked about this. We talked about that a lot. Here's the never do's. Don't try to put it back. Don't try to put it back, and don't use tinfoil. You think that might sound stupid, but they used to use tinfoil, and tinfoil is sharp, so it would end up cutting the colon. Where there was an injury before, now there is. So that's a big deal, and it's a big infection risk. The only thing I'm going to say about trauma for the genitourinary system, make sure you are looking in male patients for priapism. If a patient has priapism, then they're probably insulting their spine. So the spinal cord itself might have been insulted. They might have a neurological injury. Priapism means a spontaneously induced neurological, what word can I use to describe priapism? All that's coming to mind is hard on, but that's all I got. Erection, that's the word. Sorry, I was going back to 8th grade biology. If the patient has a spontaneous erection and they have a traumatic injury, you need to think the spinal cord is broken. We talked a lot about pelvises and how important they are. I think this is all. If they're peeing with you, which is odd, they might not be doing that, but sometimes they do that spontaneously, and that pee is bloody, I gotta really be concerned about that bladder. Again, these patients are going to be complaining of significant trauma, abdominal pain. It's going to be rigid, distended, very tender to palpation. That would concern me for, quote, hot belly. Okay? I'll let you read the sexual assault stuff, but I do want to remind you that not every facility is capable of handling sexual assault patients. There are SANE nurses, that's SANE, sexual assault nurse examiner. Those are specifically qualified, certified individuals who can testify in court as to chain of custody of evidence and the process in which they examined a sexual assault patient or victim. So in our area, that tends to be the Medical University of South Carolina. But be familiar wherever you go to work with who is your SANE nurse facility. You can't take these patients everywhere. I remind you that we don't want trauma patients of a sexual assault nature to wash their clothes, wash their bodies. We don't want to remove evidence. We don't want to lose evidence. So be careful of that. They have the right to, but we want to discourage it. All right. Peritonitis. We see the T, so then that means the thorax. If it was perineum, then that would be the space between the front genitalia and the rectum. But this has a T in it, so then that means it's the lining around the thorax. So inflammation of the peritoneum would most likely result following the injury to what? So we know that inflammation tends to be infectious. That's an infectious process. And so which one of these would line up with that? Anyone? The liver, solid. Spleen, solid. Kidney, solid. Lacerates and bleeds. Lacerates and bleeds. The stomach is dirty. It is dirty. If it were to, it's hollow. If it were to rupture and empty its contents into the abdomen, it would grossly inflame and cause infection to the peritoneum, which is the lining around the thorax. Which of the following organs would be most likely to bleed profusely if severely injured? Very good. The liver is our big one that we worry about. A, the liver. Which of the following statements regarding intra-abdominal bleeding is not true? This one's pretty easy. Come on, people. Come on, let's go. Yeah, the absence of pain and tenderness rules out nothing. Rules out nothing. I always say that the presence of something is way more indicative than the absence of it will ever be. What do I mean by that? If someone has a sign or symptom, that is very helpful. The absence of a sign or symptom is not as lucrative. Okay? It may be helpful, but it's not as powerful. It doesn't have as much weight as the presence of something. Just because they don't have pain yet, tenderness yet, doesn't mean they don't have intra-abdominal bleeding. So, which one of these is a lie? The absence of pain and tenderness ruling out intra-abdominal bleeding is a lie. D, I want to touch on D again. Bruising may not occur immediately following the injury. That's true. Bruising tends to be later. So significant injury may cause acute bruising, but a lot of bruising gets seen at the 1 hour, 2 hour, 3 hour, 4 hour mark, not in the time frame that we see the patient. So don't forget that there's stuff hiding from you. There are injuries hiding from you. Even when seatbelts are worn properly and airbags deploy, injury may occur to the what? Think about how seatbelts are supposed to be placed. Yeah, I'm still worried about the pelvis. Depending on the speed, when you wear a seatbelt, that lap belt is supposed to go underneath your belly line, and it is supposed to be deployed across the bony structures of your pelvis. That most forward, most anterior bony structure is the iliac crest. That's where the seatbelt's lap belt is supposed to be. If your speed is high enough, it will keep you in the car, it will keep you from being ejected, but it will not necessarily keep you from being injured or potentially causing injury to your pelvis. So it wants you to recognize that high-speed collisions, even with restraint, tend to cause injury, especially to the space that contacts the restraint. While inspecting the interior of a wrecked automobile, you should be most suspicious that the driver experienced abdominal injury if you find the lower dashboard is underneath where the lower extremities are. I would be torn between A, but A is more suggestive of the chest. And C, a crushed instrument panel. The instrument panel is definitely arguing that the patient's chest and abdomen struck. However, it's specifically wanting to talk about the abdomen. And airbags are notorious for causing abdominal injury. You should most be suspicious of experiencing abdominal injury if the airbags deploy. I'm torn between B and C. What are y'all going with? Okay, Shy's going with B. You know what, Shy? I'm going to go with C because C is definite. B is a maybe, but if that instrument panel is crushed, that is a big deal. That is a huge red flag for me. So I'm going to go with C, and they went with A. Isn't that lovely? Now, A makes sense, but I don't like A for the abdomen because they talk so much in the book about it being referred to the chest. But I get it. I mean, the steering wheel is up and down, top and bottom, and all around. So I get it. I don't think the question is worded very well. I don't like this question. I don't hate you if you were looking at C. D is more suggestive of lower extremities, so that one wouldn't have made sense to me. The airbags deploying, that's a maybe. They're supposed to not cause injury, although we know they can. A and C would have definitely been good answers for me. So remember the one they chose. Other than applying a moist, sterile dressing covered with dry dressings to treat an abdominal evisceration, an alternative form of management may include what? Dry towels, just clean it with sterile saline, trauma trousers is what we used to call those, applying PASGs. That's stupid. C is stupid. You can look up what PASGs are. We don't use them anymore. Or D. Yeah, we talked about that. Keep it occlusive. Occlusive is also going to keep heat in. Okay, so you can do moist sterile dressings covered with dry dressings, or because those dry dressings are going to keep the heat in on the moist dressings, or you can do this big occlusive dressing presentation like maybe saran wrap. You are transporting a patient with possible peritonitis. Okay, it's got the T in it. Following trauma to the abdomen. What position will the patient most likely want you to put them in? We've talked about this in the medical chapter as well. Yeah, B, Jason is correct. They're going to want to be in that fetal position. When your belly's hurting, when your thorax is hurting, you're going to want to be in that fetal position. 16-year-old boy playing football struck in the left flank. We talked about what flank is related to. During a tackle, stable vital signs, but severe pain. You should be concerned about what? Yeah, flank is kidney all day. Flank is kidney all day. The term hematuria. What is that? We got urea. That's an easy one. And then hema. We've talked about what that is 100 times. Blood in the urine. When caring for a female with trauma to the external genitalia, the EMT should do what? Local pressure for bleeding control. Pack the vagina. We know that is a stupid answer. We don't pack the vagina ever. Remove impaled objects. That's also dumb. And cover open wounds with moist sterile dressings. We didn't say anything about moist and sterile. The only one here is A. Apply gentle pressure to control bleeding. That's completely allowed. So 10 is A. All right, it's 8:05. We'll come back at 8:10. Okay, 8:10.
You are now muted.
around. Thank you, Siri, but I did not need that information.
You are now unmuted.
All right, guys, can I get some hands up, please? Who's back in class? Brooke, where you at? Max, where you at? Thank you. And that is everyone. Thank you. All right. Orthopedic injuries. The big thing I want to remind you here is if it's isolated, we splint it, right? So if we're talking about a patient who doesn't have a lot of injury, who's not a trauma alert, who's not an emergency, then you would splint an orthopedic injury, like a long bone, like a joint. We talk about doing that in the lab, right? However, if the patient is multi-system trauma, there's organs that you think are broken, and there's bones that are broken, then you would place the patient in spine motion restriction because the backboard is a full body splint. A long spine board is a full body splint. So when we think about the combi carrier, okay, last week you looked at the combi carrier. There was a video on that. The combi carrier arguably being one of the best spine motion restrictions tools that we can deploy out there because we want to minimize manipulation of the spine when we think someone's been injured like that. So if there's multi-system trauma, you do not go splinting individual injuries. You would put the patient in spine motion restriction, which would be a full body splint from head to toe. I want to remind you of that. If we were to get caught up splinting a broken arm and a broken leg when a patient has likely internal injuries, then you are going to do nothing but make them look better for their casket. If something's broken, that is nowhere near as bad as something internally bleeding. So do not get distracted by big old broken arms or big old broken legs. We know that they're dangerous. We know that bones that are broken do bleed a lot. So don't forget the big picture. If the patient has multiple injuries, if the patient is multi-system trauma, spine motion restriction, not individual splints. I should be able to ask you what type of splint is a long spine board, and your response should be a full body splint. From this day forward, you need to have that ready to go on the tip of your tongue. More importantly, you need to be able to actually apply that in the field. We do see people who negate transport, who negate calling trauma alerts, who negate getting the patient to the right definitive care to splint some type of injury. Stop doing that. In this chapter, you're going to hear about traction splints for femur fractures. Give that your attention. I want you to review video on traction splints. I'm going to put that in your discussion board. Okay? This is going to be another big discussion board. All right? Because I'm not going to teach you traction splints in class. The book does. We'll talk about it. You'll see video on it. You can't be tested on it. And it isn't commonly used in the pre-hospital setting. Why? Because it would need to be isolated. How often will you find someone who has broken the femur without breaking something else? It takes a lot of pressure and force and energy to break a femur. It is not likely that that energy was not also encountered by other parts of the body, resulting in multi-system trauma. It happens. It's out there. We do see isolated femur injuries. We do put those on traction. We do have traction splints on the ambulance. I encourage you to review the video that we will attach this week about traction splints. But we don't use them a lot because it's likely that the patient has other things going on. So we just put those patients on a long spine board. When you're in the psychomotor exam and you see talk of femur fractures or humerus fractures, don't go splinting those things because we don't give you non-emergent patients in the psychomotor exam. We only give you emergent patients. And since they are emergent patients, you should deploy a long spine board, not individual splints on the arms and legs. I hope you've heard this talk loud and clear. More importantly, I hope it paints a picture of what you should be doing in the field with your patient, okay? It takes a lot of time to splint things. Arguably 5 minutes at a minimum per extremity. That's what the station would say. If you look at the long bone station, if you look at the joint station, you get 5 minutes to do that type of splinting. Well, that would be 5 times 4, so 20 minutes, and that's far beyond your 10-minute allowance for on-scene time for multi-system trauma. So I hope you understand why we don't do a ton of that. Okay? Now, if you go to little Johnny and he's broken his arm, it's isolated, there's nothing else, we're not concerned of other things, then great. Let's focus on splinting that to prevent further injury, helping with some pain control. Thinking about our Rice's mnemonic: rest, ice, compress, elevate. That is our approach for isolated injuries. Okay? So you got to think about both sides of that coin when you read this chapter. Open fractures are exactly what we say. They're open. You're looking at the bone and there's an open spot there. I want to remind you that bones can come out of the skin and go back in. The most obvious and gross open fracture, and by gross I don't mean ugly, I mean large, I mean a big picture conversation. The most gross open fracture is super visible. There's bone outside the skin. It's a very obvious looking injury. But don't forget that you can pop a bone through that skin and the bone come back into the skin and it's no longer visible. So when I see deformity and pain and tenderness over a long bone, and there is also an opening, you got to think, is this an open fracture? Commonly, that is missed for being a laceration. Do not forget your decap BTLS. That's what it's designed for. Why do we have decap BTLS? Because people keep missing stuff. That's why. If you really do deploy deformities, yes or no? Contusions, yes or no? Crepitus, yes or no? You've got to look at each individual piece of decap BTLS for every piece you're palpating. And you got to ask yourself if that stuff is there, yes or no. If you do that, you really do find most injuries. Okay? That's the whole point of it. So open fractures, that's what it is. A closed fracture, how do I know there's a closed fracture? Well, you're looking at a humerus that's 3 times its normal size. Well, that's probably a closed fracture. I want to remind you that long bones, like the tibia, fibia, humerus, and femurs, bleed a lot when you break them, especially the humeruses and the femurs. The femur being the largest, most dense, long bone, the biggest bone in the body. If you break that bad boy, you can lose 500 to a liter of blood volume in a femur. Not only am I now worried about this broken long bone, I'm worried about this bleeding, and then on top of that, you're worried about compartment syndrome because you don't have enough space to be bleeding a liter of blood volume in your arm. So then compartment syndrome becomes a worry where I have to think, is that injury now going to cause enough swelling that it can't perfuse the tissue around that area and it's going to begin to die? It's going to begin to conduct anaerobic metabolism. So that all goes into the thought of open versus closed, deformity, crepitus, and swelling and tenderness. Okay? Make sure you understand crepitus. That when you push on a long bone, it's supposed to be stable and it does not give way. If it does give way and you feel snap, crackly poppiness underneath your skin, your fingers, your hands, then that's crepitus. Do you need crepitus to be broken? No. You've got to deploy the entirety of deformities, contusions, crepitus, abrasions, punctures, penetrations, lacerations, tenderness, and swelling. I always caution people that some of the most missed stuff is the tenderness part. If someone has a mechanism of injury to an extremity and it's very tender to touch, you've got to wonder if there is a fracture that maybe isn't large, baby isn't super gross, and so then you aren't capturing it. If it's super tender enough that they don't want to have normal range of motion, tender enough they don't want you palpating it, you gotta wonder if it's broken, guys. Okay? And if it's broken, you gotta wonder if it's bleeding. Okay? Think about that. What is the difference between a sprain and a strain? We're going to talk about that. Dislocations. Dislocations can result in a loss of perfusion. A loss of perfusion is a big deal. So when we find things dislocated, we got to wonder about PMS. I go back to the sheet. I think about the fact that anything that appears broken or injured in regards to a long bone or a joint, the first rule of thumb was manually stabilize it. Don't let it move anymore. The next rule of thumb was, do I have PMS? Is there a distal pulse? Is there motion? Is there sensory function? Can the patient move it? Do they feel it? If the answer to that is yes, then we're okay. We're better off than if it were no. If a dislocation results in no perfusion, we can reduce that in the field. I want to remind you that the word reduce means to put back in its place. Okay? Reducing is an orthopedic term that means put it back in its normal, neutral, inline position. It doesn't necessarily mean that we fix it. It means we give it the best chance for proper pulse, motor, and sensory function. And if it's got PMS, then it's not going to die. It's going to live. They're going to keep their extremity. It's not going to have long life deficits. That is the point of reduction. An EMT typically has the right to reduce an extremity with one attempt if no pulses can be found and there are signs of no perfusion, like the extremity being very pale. Sensory function is in decline. I can't feel it. It's tingly. It's numb. It's weird. It doesn't feel right. I can't move it. Those things would be signs that I need to reduce this. Obviously, your local guidelines are going to decide whether you do or don't have reduction allowance. If you don't, you need to splint it how you found it and emergently transport. Even if it's like an isolated ankle, if something is not being perfused, that is a surgical emergency, or at least a potential surgical emergency, and our goal would be not to allow long life deficits. The longer it goes without perfusion, the more likely that it will not have the range of motion and function that it had prior to this event. That's what we think about when we think about orthopedic injuries. Okay, so that's the dislocation part there. Sprains and strains. You need to pay attention to the defining points of sprain and strain in the book. You're going to see test questions that ask you the difference between a sprain and a strain. You need to know that a sprain and a strain is defined by whether it involves tendons or whether it involves ligaments. Pay attention to that. When we talk about sprains, we tend to be talking about stretching and injury to the ligaments. Okay? When you talk about strain, it's stretching beyond its normal of the muscle and tendons. Okay? I also want to remind you of what a tendon is versus a ligament. A tendon is MTB, muscle to bone. The T is a tendon, muscle connected to bone. So tendons connect muscle to bone. Ligaments is BLB, bone, ligament, bone. Bones connect to bones via ligaments. Whether something is a sprain or a strain is about whether the injury occurred to a muscle and tendon or whether we're talking about ligaments. Pay attention to that definition. We already talked about pelvic fractures and what to do with that. Amputations. Don't forget that we can put them back on. If an amputation is found, you need to focus on bleeding control if bleeding control is necessary. Tourniquets are your friends. With the actual part that's amputated, it needs to be kept clean, moist, and cool. Keep it on ice, but not directly touching ice. Keep it on ice, but not directly touching ice. Sarah Armand, was that a mistake or do you have a question?
Sorry.
Okay. All right, so we've addressed all of the things on this slide here. The rest is up for you to read, okay? I've told you what to focus on. I'm going to just look through and make sure I'm not missing anything that I know will show up in the material or that I think is really important for practice. You're always going to keep getting these stupid questions about what is skeletal, what is smooth, what is cardiac muscle. I hope you know that by now. Striated equals muscle. It equals skeletal muscle. Striated is strong. S for strength. Well, the strength is needed to move your arms and move your legs. That's your skeletal muscle. Smooth is about bladder control, urinary habit control, maybe even esophageal related control and swallowing and peristalsis. And then cardiac is pretty obvious, okay? So striated and skeletal are the same. They move your bones. Smooth is about tracts and digestion and urinary. Cardiac is obvious. I'll let you read about that. You got to know the bones. Again, if you don't know the anatomy, you don't know how it's supposed to be. If you don't know how it's supposed to be, you don't know how it breaks. If you don't know how it breaks, you can't fix it. So that's just common stuff, okay? You already have been told what bones are really common, the ones we really think about and use a lot. Definitely make sure you can name the long bones that matter. Humerus, femur, tibia, fibia. Think about where you can find your pulses. Think about PMS, pulse, motor, and sensory function. We check radial, fingers moving, can you feel it? Then we check on the feet, the dorsalis pedal pulse, which is the pulse on the top, middle of the foot. Okay? And so can they move their toes? Do they feel their toes? Think about PMS times 4. There are no patients who don't get a PMS assessment. Commit that to your memory now. Also remember that I have a video of a trauma assessment up on the Moodle. You should be watching it. Okay? You are going to see some questions about comminuted. Okay? Comminuted is broken a lot. That's what that means. Okay? When something's comminuted, it is basically disintegrated. And I'm being global here, but I just want to give you a visual that helps you remember these terms. A fracture in which a bone is broken into multiple fragments. So think about a very bad busted up bone. Okay. Green stick is mostly about pediatric patients, and it's about bones that aren't fully calcified and osteophyte. They are not completely developed, and so they bend more than they break. So children tend to be talked about as green stick fractures, and that just means that it isn't going to present as grossly obvious as a 55-year-old male who breaks their humerus. That thing's going to be huge. It's going to be very deformed. It may be even shortened. It's because they have a fully osteophyte, calcified bone that breaks. A pediatric patient's bone is not all the way density. It's not of great density. And so it's going to bend. And when it bends, think about that, limb that you tried to break, but it's not quite breaking. It's more bending. You're going to still get injury. You're going to still get trauma, but it's not going to be as grossly obvious. So your tenderness is going to be a big deal. Your maybe even swelling is going to be a big deal, but it's not going to be as obvious when you have a green stick fracture as when you have this big, comminuted, clearly broken bone. When you think about hips, okay, now obviously this is a tibia-fibia deformity here, and we've got some shortening on the right side versus the left. When you think about hips and lower extremity fractures, always remember to look for rotation and for shortening. The legs and the arms are about the same length from left to right. There is a little bit of difference, but not much anatomical innate difference. When you break your hip, when you break the femur, when you break the tibia, the rigidity that allowed for that normal foot presentation and leg presentation is now gone. It's now insulted. It now is not rigid. It now is deformed. You're going to have shortening from one side to the other. That's a big indicator. So look at them, compare them. Anytime you're thinking about anatomical injury to the orthopedic system, look at one side and compare it to the other side. Look for rotation. Is the foot rotated out laterally? Is it rotated in medially? And is there any shortening of one side versus the other? I'm going to let you look at sprains and strains, but I remind you that a sprain is typically talking about joints, ligaments that have been stretched beyond their normal function and injured. So you have an injury due to stretching. With a sprain, we're talking about joints. And if you remember, bones connect to bones via ligaments. So there you go. With a strain, on the other hand, you're talking about muscle and tendon stretching beyond its normal. And so then there's injury to muscle and tendon. That's what separates the two in definition. We were talking about amputation and the possibility of being reconnected. We can put things back on. You've got to keep the foot that's cut off. You got to keep the arm that's cut off, and you've got to keep it moist, sterile as possible, clean as possible, and cool. So we want it on ice, but we don't want the tissue directly touching ice. So ice water would be better than ice just straight on the tissue, because if you ice tissue, it is damaged beyond repair. So we don't want it iced. We do want it cold. When things are cold, they don't need as much nutrients. They don't metabolize as quickly. So then we can salvage more tissue. When things are directly put on ice, it injures the tissue. Again, the golden hour of trauma is a very big deal. It's definitely also a big deal for preserving limb viability. If we're outside the hour window, the patient's mortality chances go through the roof, and we start losing the ability to put things back on. Fingers, arms. I want to also remind you that teeth are very successful in replantation. If a tooth is fully intact, keep it cold, keep it moist, keep it sterile if possible, and bring it with you. They can put teeth back in. Otherwise, the patient's now getting an implant, which has also come a long way. So there's a lot of technology for that. So that's great. But you'll actually be surprised how replantable an intact tooth is. Always focus on a good primary, okay? Don't get distracted by big broken bones. We know about splinting. We have sheets for splinting. I'm not going to go through that. I'll let you read it. Please take a look at pelvic binders. It will be on the discussion this week. Hazards of improper splinting is that we interrupt PMS and that we cause more injury. Sling and swath if it's the shoulder. Sling and swath if it's the shoulder. We typically, for the knees and elbows, they hurt so bad, if you are not going to reduce it, which depending where you work, you are going to try to reduce it, but if you're not going to reduce it, then put a pillow splint in place. Take a pillow, wrap it around the extremity the best that you can, and splint it how you found it. Get the patient to the hospital so that they can get some pain control on board and reduce this back to its normal position. There's your palpation, your gentle push down, gentle push in of the pelvis. Gross pain or instability should be splinted, should be put in a pelvic binder. Never try to traction a broken femur if you think the pelvis is involved. If you're going to traction something, you need the other bone structures around it to be very intact, right? Traction means to pull something into neutral inline position. So you can't do that if the hip is broken. You can't do that if the tibia or the fibula is broken. You can't do that if you have a knee problem. So think about that. When you traction something, it needs to be isolated. So if you're going to traction a femur, that needs to be the only thing broken. Remember when people fall, question how high they fell, question what they landed on. Body part and surface. Was it grass? Was it pavement? Was it rocks? Was it water? Did you land on your feet? Did you land on your head? Those things matter. Are you taking blood thinners? And did you lose consciousness? Those are the big questions for fall. Also, did you fall because you lost your footing, or did you fall from a medical reason? I was on the roof and I got dizzy and then fell. Well, that's a medical emergency and a trauma emergency. I got on the roof and I was feeling deep chest pain and then I fell. That's a medical emergency and a trauma emergency. Don't forget that you can have both. The vehicle crashes into the gas station. You better check a blood sugar, because which one came first? The trauma emergency that you're seeing in front of your face, or a medical emergency that preceded it? You could have both. Your Rice's mnemonic, we've talked about that. You guys know what compartment syndrome is by now. We talked about that. All right. Skeletal muscle is also called what? I specifically said it. Speak up. Yeah, striated muscle, because striated equals strong. S for strong. You respond to a soccer game, 16-year-old male, ankle pain, deliver him to the hospital, physician tells you he suspects a sprain. What is a sprain? There is disruption at the joint and the bone ends are no longer in contact. Maybe. That's not quite good enough. The patient has an incomplete fracture. No, sprains are nothing to do with fracturing. The bones are not broken. Stretching, tearing of the ligaments, or partial temporary dislocation. Now that sounds good. D, the muscles of the ankle have severely stretched, resulting in displacement. Well, that would be a strain. So if we're talking about a sprain, we're talking about joints and ligaments. And so you guys are going with C, and I agree. C, a sprain is a joint and ligament thing. A strain is a muscle and tendon thing. A young male has a musculoskeletal injury and is unresponsive. You may not be able to assess what? They're unresponsive. Yeah, sensory and motor functions will be a little more difficult. There are ways to do it, but it's certainly going to be more difficult. The purpose of splinting a fracture is what? This is a little bit of a butthole question, okay? The obvious answer is we splint things to keep PMS intact. We splint things to reduce further injury. We splint things to help with pain control and swelling. But why is there pain problem? Why is there swelling? Why can it further become injured? And the answer is, when you break things, the little bony fragments can injure the tissue, can injure the vessels, can make things bleed more, can make things swell more, make things more painful. And so the answer, reduce the fracture, does not have anything to do with splinting. Reduce swelling in the adjacent tissues. We know that that's the end result. So if you went with C, I understand why. And then D is force the bony fragments back into anatomical alignment. That's not quite what splinting does. So you should be between B and C, Charlie. And you're going to find that they like the answer for B. B is the cause and C is the outcome. Okay, so I'm not angry if you were between either one of those. However, we actually are trying to keep bony fragments from causing more injury. That's why we splint fractures. The motorcyclist crashes his bike and closed deformity to both his femurs. That's a big deal, guys. So that's a liter of blood volume potential between both the 2 liters of blood he could be losing. He's conscious, but he's restless. Oh, there's some mental status change. That's an early sign of shock. His skin's cool and clammy. That's shock. His radial pulses are rapid and weak. That's shock. The most appropriate splinting way. How would you splint this guy? We addressed it aggressively. Yeah, you would secure this guy with spine motion restriction. And we remember that SMR is all of it. Backboard, straps, head blocks, cervical collar, the whole shebang. Why? Because it becomes a full body splint. You don't go individually splinting someone who is shocky. The answer is Charlie. Or more importantly, is the why. The answer is Charlie. To effectively immobilize fractured clavicles, so this is the shoulder, what do we do? That's sling and swath blade. Yep, that's correct, guys. Good job. Jason Eater, you are on it tonight. I'm loving it. A patient tripped and fell, landed on their elbow. They're in severe pain, obvious deformity. What should we do? Follow the sheet. Follow the sheet. Come on, people. What do we do? Follow the sheet. What do we do first? We stabilize things up above the injury and below the injury, and then we check for pulse, motor, and sensory function. So that question was just simply following the order of operations of the sheet. When treating an open extremity fracture, you should what? Yeah, let's make sure we're controlling bleeding and dealing with the wound before we go splinting it. The splint will help with bleeding control. It will help with wound treatment, but make sure we're dealing with the wound before we splint it, because we don't want to splint something and then have it start bleeding and becoming a problem. So B is the answer. Which of the following musculoskeletal injuries has the greatest risk of shock? Talked a lot about this. Yeah, pelvis, man. People are going to die if we miss pelvic fractures. A patient's injured their knee riding a bicycle, lying on the ground, flexed leg, severe pain, can't move it, and there's deformity. Distal pulses are present and strong, so we do have perfusion. The most appropriate treatment would be what? We got good perfusion, lots of pain. All right, so you're going to be a little mad at me because A is definitely one of the best things we do in practicality, but it is not addressing the medicine. The truth is we're supposed to splint things in the position it was found, if possible, when we have good perfusion. So A is too specific. B is more global. And that's why B is the answer. A is just a potential way that you would accomplish B. So remember, the National Registry wants to know the most correct answer. A is a correct answer, but it is not the most correct answer. I might elect to go with board splinting. You might elect to go with wrapping it in a pillow. But both of us would be trying to achieve B. All right. It is 8:44. At 8:50, we'll conduct the last chapter. Take a break.
You are now muted. You are now unmuted.
All right, kids. We're getting back to it. Environmental emergencies. This is a pretty big chapter. You're going to see why. I'm going to go through the specifics of the emergencies that it talks about, and you're going to do the reading. Otherwise, we could lecture half this class on this one chapter. This is a pretty big chapter. There's a lot of information to keep in mind. So let's go through the emergencies that it covers and talk about the specific treatment that I would be expecting you to know for each one of them. All right. Submersion events, we're going to talk about that as drowning and near drowning. Okay? Drowning and near drowning do not always occur immediately. If anyone has struggled under the water, they can die later, something we call secondary drowning. Okay? So we have to be cognizant of the fact that if anyone has a water-related event and they were struggling to stay on top of the water, they were struggling for any reason in the water, that is a person I would want to get checked out at the emergency room and potentially be admitted for observation for 24 hours. Why? Because should you survive the initial event, you might die later. Your lungs can fill with fluid later when you're asleep, especially when we think about saltwater related emergencies. Water follows salt. You get a bunch of seawater in your lungs, even if you get that out and clear it, you could eventually run into a flash pulmonary edema scenario where the patient then fills their lungs with fluid because water follows salt. So we got to be careful with that, all right? Any drowning related event also concerns us for spinal injury. If the patient is not conscious and able to tell us that they did not injure their spine, we will assume that they did. You've got to remember that. That is a very big principle of water-related emergency management. If they're not able to tell us that they did not hurt themselves, spinally speaking, during this event, we've got to consider that they did. Okay? So then spine motion restriction comes into play. Neurological shock and us being very observant of that comes into play. Okay? The next thing we got to talk about is temperature-related emergencies. Cold, hot. Too cold, too hot. There is mild, moderate, and severe, too cold, and too hot. Pay attention in this chapter about the temperatures that it advises are too cold and too hot in the mild category, moderate category, and severe. Here's the treatment. Whether they're cold or whether they're hot, get them out of that environment. Step number 1. Get their clothes off. Step number 2. If they're cold and wet, get that off. If they're hot, that clothing is making them keep in that heat, so get that off. And then step 3, treat the actual temperature. There's 2 ways to do that. Passive and active. Passive is getting them into the air conditioning, whether that be cold or hot, getting their clothes off, whether that be cold or hot, getting them into an environment that starts cooling them or warming them passively. Actively cooling or warming someone means we are going to do something that will make their body cool or warm. An example of active would be in the cold world, we want to make them cold, so we wet them and we run air across them. We put a fan. So now we're convecting cold air around the patient, and that will cool their temperature. In the warm world, we would stack heating packs in their groin, in their axilla, and in their neck, maybe on their head. Or you could put cold packs in their groin, in their neck, in their head. Your paramedic can give the patient fluids that are warm or cold. If it's invasive, if it's full contact, that's active. If it's by letting the ambient environment become what it should have been for the patient before the emergency, that's passive. So pay attention to passive and active verbiage in this chapter. Be able to decide which is which. We already talked about what a near drowning is. We just covered cold and hot people. In the cold world, one of the things I want to mention is that cold people look dead. When you get too cold, when your core temperature drops below 90 degrees Fahrenheit, you start reducing your metabolic rate to such an extent that the patient does not need to breathe as much. The patient does not need as much blood pressure, and the patient does not need as much heart rate. What does that look like to us? Well, they look dead. Their brain starts saying, go to sleep. Their breathing is very low and shallow, and their heart rate and blood pressure are so low that it's hard to palpate and feel. We think they're dead. So we have a rule in EMS that you're not allowed to be dead unless you're warm and dead. People have been successfully resuscitated at the 60-minute mark who were hypothermic. So, the body's natural response to getting too cold will save your life. However, it can make responders think that you're dead. We got to be careful with that. Also, it is not smart to aggressively jostle a cold patient. If a patient's core temperature is below 86 degrees Fahrenheit and we jostle them, move them about, invasively manage their airway, we're kind of being too aggressive, the patient will go into ventricular arrhythmias that we cannot get them out of. You have to remember to be very careful and cautious and soft in treating hypothermic patients who are severe. We're talking 86 degrees Fahrenheit. We're talking 87, in that very low category. Those are patients who are susceptible for going into ventricular arrhythmias that cannot be resolved. Okay? That's what you should think about on the cold side. Once they lose the ability to shiver, now we're getting into the moderate and severe world. And once they are getting below that 86 degree mark, we're severe and we shouldn't be jostling them around. And think about the fact that their metabolic rate is so low, they're going to look dead. Okay, let's switch over to the hot. The things I want you to think about with the hot. Once you get hot enough, you're going to have one of two things occur. You're going to have hyperthermic fatigue, or you're going to have heat-oriented exertional stroke. How do you know you have one versus the other? If the patient is tired, fatigued, sweaty, hot to touch, that is heat exhaustion. If the patient has a neurological deficit, that is heat stroke. If a patient can no longer sweat because they've run out of sweating and they are still hot to touch, dry as a bone, and they are altered in mental status, that is a heat stroke. The moment the brain cannot function because of temperature, it is a heat stroke. Being tired and sweaty and clammy and fatigued and lethargic because you haven't been drinking enough, you didn't get enough Gatorade, that's all exhaustion. Muscle cramps, that's all exhaustion. They're still sweating. In the stroke world, they stop sweating. They're super hot to touch. That temperature starts getting into 105, 106, 107, above 104, and they're no longer sweating. Their mental status is starting to become a deficit. Now we're talking about heat stroke. We're susceptible for seizures, vomiting, airway compromise, and they will look like a stroke. They may even be unconscious. This is a patient we might dump in ice water for 15 minutes or until we can get the core body temperature below 104 degrees. Here's the problem with heat stroke. Whatever damage is done is done. Once you get above 104 degrees and you start reaching the 106, 107 zone, that tissue that you're killing in the brain is dead forever. Heat exertion stroke is a really big deal, and it kills a lot of really healthy people every year. We got to think about that. There are protocols and policies for dunk tanks. In your sports programs like football and outside heat-related sports, you will see the exercise science folks, the exercise trainers who are trained in medical emergency response, they have dunk tank protocols. Some EMS agencies have dunk tank protocols where a patient is now altered in mental status and they have a core temperature above 104 degrees, maybe even 5, 6, 7. We're going to dunk that person in ice water, not ice water, until we can get that temperature below 104 degrees because we want to protect the brain. Okay? So that's the conversation of cold emergency, hot emergency. I'll go through a little bit more as we get through. Dominique has a question. Will they not go into shock because of the temperature difference, or will that outweigh the stroke? Oh, they're going to look shocky. Their mental status will be in decline. They will be extremely tachycardic. Breathing will be dependent, maybe even Cheyne-Stokesy, because the brain is taking such a hit. They may even be in this pattern of fast breathing, slow breathing, and intermittent apnea. They will look like a stroke. They will sound like a stroke, except it's all because of temperature. And if we don't get the temperature down, they will die, or they will have lifelong deficits. Can't walk anymore, can't speak anymore, can't think anymore, can't work anymore, stuff like that. Okay, so yes, they will be in shock. They will look like they're in shock. They run out of the sweating mechanism. They run out of the thermodynamic mechanism to warm yourself or cool yourself. In this case, it's cooling yourself. Okay?
Listen, is there like a treatment with water in the like hot world? Like if they were having a heat stroke, could drinking cold water help them?
Well, by the time they're having a stroke or heat stroke, Drury, their mental status is not able to be given things by mouth, right? We know that one of the principles of giving anything to someone by mouth is that they are able to swallow upon command. Well, if you're in the definition of heat stroke, this is a person who has neurological deficit. I would not want to be giving that person cold fluids by mouth. We would focus on external management of the patient, like dunking them in ice water. If you don't have a dunk tank, you would get that person naked, wet them, and then put moving cold air around them, okay? Convective cooling, which also is very successful, okay? That's a lot of what the ERs are doing now. They will hit the patient with cold fluids, they'll get them naked, they'll douse the patient in cold fluids, and then they'll take fans and put it over the patient's body, moving that cold air around the patient, and it will rapidly drop their temperature. We also have these things called bear huggers and Ticotherms. These are big devices that can heat and cool people by running water through a system that basically is draped over the patient. So there are many ways we achieve this in the field. The most common is tank dunking or by convective cooling. Convective means moving air, so we take cooled air and we move it across the patient, and we have that patient wet at the same time. That is pretty successful in lowering core body temperature. The paramedics are going to start large bore IVs and give these patients cold fluids. You got to be a little careful with that. There's a lot that goes into that. On the other side, the reverse side of this coin, on the cold side, we can also give warm fluids. So that would be an active treatment, not a passive treatment, right? Tank dunking, that would be an active treatment, not a passive. So if you were an EMT on an ambulance and you had a heat stroke patient, not a paramedic, you're an EMT, I would get them to an ambulance, turn the air conditioner on as cold as possible, get the patient naked, get ice packs in the groin, ice packs under the axilla, ice packs around the neck, ice packs around the head, wet the patient, start moving that air, maintain ABCs, keep a good airway, keep good circulation. That core body temperature management is what's going to save the patient's life. Okay? On the other side of that coin, on a very cold patient, remember that they're not dead, probably. Okay? If they don't have a pulse and they're not breathing, okay, then do CPR. But most likely it's because their metabolic rate is so low. Get them to your ambulance. Get that cold, wet clothing off of them. Get them dry. Turn the heat up as high as you can get it. Put hot packs in the groin, in the axilla, on the neck, over the head. Get good warm blankets on the patient. Start warming that patient and get good ABCs, airway, breathing, and circulation control. It's a lot of common sense is what it is when you think about managing serious temperature-related emergencies. Okay? All right, let's talk about bites and envenomations. It goes all over the place. When you look at the protocols or the guidelines related to what do you do for this type of bite? What do you do for that type of bite? What about this? What about that? It's very different from agency to agency. So I'll focus more on the book. Okay? The book wants you to know the difference between a black widow spider bite and a brown recluse. Black widow spider bites attack your ABCs. Your ability to breathe, your ability to maintain your airway, your ability to circulation, your neurological system. A brown recluse spider bite is a histotoxin. Histo means tissue. It's a tissue toxin. It will cause a nasty infection and it will cause necrosis of the tissue where the tissue actually dies. So know the difference. Black widow actually attacks the brain and ABCs. So that's pretty bad. And then brown recluse attacks the actual skin, causing these big, nasty, horrible infections. Okay, so think about those two. That's in the book. Snake bites. It's all over the place. Who wants you to do what? What snake bites are able to be treated where? You need to know that in our area, in North America, we have two main categories of snake bites. Coral, which is really, really, really bad. And then all the rest of them, which we would consider pit-related, viper-related, like rattlesnakes, water moccasins, those types of venomous snakes. The good thing is, for the non-coral snakes, we have something called crofab, which is an antivenom that treats most of the North American things. And then most ERs also carry coral snake antivenom as well. So we can treat these things. But what do we do in our setting, the pre-hospital setting? Number one, keep the patient calm. If the patient gets excited, the more they breathe faster and have a faster heartbeat, the more they move that toxin around their system. So we've got to keep them calm. There's a lot of data that says just staying calm is a pretty big factor in your outcome. Okay, so staying calm. We might put ice packs on the envenomation site. You certainly want to look at the envenomation site and make sure that it has 2 holes, not 1. And you want to draw a circle around the swelling area so that if the swelling increases, it's very obvious to you. And then emergently transport the patient to a hospital that says they can treat the patient. You might fly this patient because not all hospitals carry antivenom. So wherever you go to work, you will have developed a resource page that says, who is our go-to facility for this? Do we fly these patients or do we go to Trident? What do we do? Around this area, you can pretty much go to any of the hospitals because they're all carrying the same stuff. For your more odd, weird envenomations, like the time in Mount Pleasant when a buffoon viper got loose, which is a super venomous snake, not of this country. That patient, if a person was to have gotten bitten, and they did not, thank God, but if someone had, we would probably fly them to Atlanta. Atlanta has a pretty big department that goes after envenomation medicine. They have a specialty for this. So any toxicology department looks at this, can deal with this. So the Medical University of South Carolina is a good one. The hospital in Atlanta, Emory Medical Center, is a good one. So we might fly this patient. If in doubt, go to MUSC. Trident carries crofab. So most of your places are going to be able to deal with your snake bites. Okay? Pay attention to what the book says. Sometimes you ice pack the site. You draw a circle around the site to measure swelling. What you don't see is we don't suck out poison. We don't put tourniquets on. You might elevate it. Sometimes you don't elevate it above the heart. Read the book in regards to that verbiage. Okay? The other area of this chapter that we have to talk about is altitude-related emergencies, whether that be diving or climbing. Obviously, as you get lower in sea level, your atmospheric pressure, does it increase or decrease? Anyone?
Increase.
Right. So as we get up in higher altitudes, we decrease in altitude pressure or barometric pressure. As we dive deep, we increase in barometric pressure, which tends to have a disproportional relationship, basically meaning it goes in reverse of how we think. Okay? So when we dive deep, you can't just come up. If you do, all of that pressure that was keeping gases inside your body confined doesn't have enough time to equalize and normalize, and it can cause things like stroke, heart attack. So diving people have to come up slowly. Here's the point from the book. If someone is complaining of anything, headache, dizziness, stroke-like symptoms, chest pain, and they were diving within 24 hours, we have to be grossly concerned that this is a diving emergency. The book is going to talk about bends, so sure, read about that, look at that. But on a global scale, if you were scuba diving or diving below sea level within 24 hours and you have a sudden onset of symptoms, it is very concerning that you will have a dive-related emergency. Put that patient on high-flow oxygen, emergently transport to a trauma center where the patient will be considered for dive-related treatments like hyperbaric chamber treatment, where we re-dive the patient and slowly bring that patient to an appropriate atmosphere, alleviating their emergency. I'm not going to go through the individual types of dive-related emergencies, nor does this book get deep on the dive-related emergencies. You just need to remember this. When you go down deep, there's a lot more pressure than you're used to. The gas and fluid inside your body gets compressed by that additional pressure. When you ascend quickly, too quickly, that gas, that fluid, does not get to properly equalize, and that will cause emergencies like emboli, chest pain, maybe heart attack, brain pain, headache, dizziness, neurological symptoms, possible stroke symptoms, potential stroke. Those little gas bubbles get lodged in the vessels just like plaque, just like blood clots. So that's where you get it. I don't want you to focus on the individual names of stuff as much as I want you to focus on why, the physiology of why. So that's the deep world, okay? If you dive down, you got to come up slowly, period. The gases that you're using while you're down there, they matter. Someone who presents symptomatic within 24 hours of a dive, you've got to be very concerned that that's a dive-related emergency. I'll let you read the rest. Let's move over to the high altitude side. As we increase in altitude, we start playing with less barometric pressure, which also causes some problems. There are many gas laws like Boyle's, Charles, Dalton, Gay-Lussac's that come into play when we change altitude as it relates to the gases around us. Gas laws are directly impacted by your altitude. As we climb a mountain, the pressure around us decreases. So all of the control you had on keeping your blood in the right place, your fluid in the right place, your gases inside your body in the right place, well, now there's not enough pressure to do that, and so some of them start acting the fool. Again, I'm staying away from giving you specific ones, more so towards the global conversation. When you do that, you get headaches, you get dizziness, you can have strokes, you can have heart attacks, you can have eardrum issues, teeth issues, lung issues. I'm not going to focus on the individual ones. I'm going to focus on if that person is higher than they're used to, you've got to be concerned that whatever you're seeing is an altitude-related emergency. Step one, get them out of that altitude. Put them on high-flow oxygen, transport them to a trauma center where they can decide how to treat the patient's altitude. There are many different treatments and options that might apply to the patient. Okay? When we get to the area, I'll talk a little bit more specifically, but that's the general conversation. If you're within 24 hours of a gross change in altitude, and you now present with anything, especially neurological things, especially chest pain, especially breathing trouble, you've got to be concerned that that is related to the altitude that the patient was not used to, acclimated to. Okay? There you go. Electrical injuries. We already discussed that when people are injured by electricity, whether that results in this big, ugly, nasty burn, whether that results in unconsciousness, cardiac arrest, the most common response is arrhythmia, an interruption of their breathing, an interruption of their cardiac rhythm, resulting in cardiac arrest. Even if they do not present to you now in cardiac arrest, over the next 24 hours, depending how much exposure the heart and brain and lungs were exposed to this electricity current, they may go into cardiac arrest. You got to think about that. The burns are treated the same. The focus should be on ABCs and the potential that the patient might go into an arrhythmia and present with sudden onset apnea or sudden onset cardiac arrest or cardiopulmonary arrest. That is the takeaway from the electrical injury side. He wants you to know that the most at-risk people for any of these environmental things are the very young and the very old. If you are sick in any way, you are much more at risk. If you have ingested any alcohol or drugs, you are much more at risk. If you take daily medications that impact your ability to compensate, like blood pressure medications, which control the heart rate, you are greatly at risk. You got to think about that, because that population should increase your suspicion that there is an environmental related emergency. Okay? Go out there. Do focus on this slide. Conduction, convection, evaporation, and radiation. You're going to see questions about what that is. If someone is warm and they lay on the ground, it's wintertime, they will radiate their warmth into that cold ground, and they will now become cold. That would be radiation. You are next to something, and you are moving heat from a good place. It is lost to a bad place because of radiation. Evaporation is pretty obvious, and convection is the movement of air, whether it's warm or cold, moving air. Conduction is physically transferring heat with direct contact. Radiation does not have to have direct contact. Conduction has direct contact. Know the difference between those two. When we breathe, we lose a lot of water and we lose a lot of heat. Remember that. All right, we already talked about that. Pay attention to those mild, moderate, severe. We already discussed that. We do not typically rewarm individual things, but if you had a protocol for that, you would be rewarming it slowly. There is a test question. You do not ever massage frozen parts. It is believed that you could dislodge crystallized, iced, frozen blood vessels or products or blood components, and those would now go into the circulation and become clots. So we do not ever massage cold parts. This is important because one of the most common things people tend to want to do when something's really cold is rub it, rub it, rub it, rub it, rub it. If it's frozen, if it's frostbite, like actually frozen, don't be rubbing it. I'll let you read the rest. Guys, definitely read this chapter. It is super important and it is pretty specific. We talked about that. We talked about heat, the difference between exhaustion and stroke. We talked about that. Told you about the heat. Told you about drowning. Make sure you're careful about spine. Always be concerned about spine. If a person went into a shallow body of water head first and they're now unconscious in the water, their cervical spine is in trouble. Reach, throw, row, then go is a normal concept for EMS. Make sure you know about it. The last thing we do is get in the water. If you are a lifeguard, you know that getting in the water to rescue people is very dangerous. When a person thinks they're going to die in the water, they will kill you in their own attempt to save their own life. So you have to be careful with that. The book is going to say, put on a personal flotation vest or device. Reach for them with an object. Throw something to them. Row out there and get them from a boat or some type of fixed object. And if none of those things are available, only then should you be risking going out there to get the patient. Even when you do go get the patient, you want to use something like a can. If you've seen a lifeguard can or a lifeguard buoy, you throw that out to them and you let them hold on to that while you swim them in. You don't ever want to try to go hands on with a person who is struggling in the water. They will kill you. That is the point to be taken away from water rescues. Water rescues are typically performed by specialized teams, especially if that water is moving. Okay? Keep that in mind. On every ambulance we have throw, row, go gear. We have personal flotation devices to save yourself, and we have throw ropes. That's what you'd want to use. You don't want to typically get in the water. The cool head prevails in the world of water recovery. Okay? All right, we talked about descent emergencies, going down into deep atmospheric pressure can cause all of those things. Ascending too quickly causes the bends. Okay, that's when you come up too fast and you decompress too quickly. That causes the bends. And again, stick to the global concept. I can't breathe, my head hurts, I feel like a stroke, I feel like a heart attack, and it's been 24 hours since I dived. That's a dive-related emergency. They probably are going to go to the Barrett chamber. Maybe, depending where you are. Especially if it's a stroke patient. Remember that dive-related emergencies can cause strokes. It can cause heart attacks. And those can be lifelong illnesses secondary to those emergencies. All right. You are going to see a couple questions about acute mountain sickness. Okay. Again, they're in a high altitude. They're not used to it. Now we got headache, lightheadedness, dizziness, fatigue, nausea, vomiting. Obviously, that's going to be related to their altitude. All right, these are the ones I want to talk about. HAPE and HACE, okay? HAPE and HACE. When you get into altitude, I said that normally when you're at a normal altitude, the pressure of the barometric atmosphere keeps all of your fluid and your gases in the right place. If you go up really high, your fluid and the gases inside of your body tend to want to wander. HAPE is pulmonary fluid wandering. HACE is cerebral fluid warming. If you respond to a person who is of a high altitude and they're not normally used to that altitude, and they have rails and trouble breathing, CPAP. If you respond to a person who is acting like a stroke, looks like a stroke, feels like a stroke, and they're at a high altitude, treat them like a stroke, get them out of that altitude, high flow oxygen, manage the airway aggressively, and treat them like a stroke. The difference between HAPE and HACE is nothing more than whether it happened in the lungs or whether it happened in the head. Here's what I caution you with. If you are at an altitude in which you are capable of moving your fluid into your lungs, you are also at an altitude that is capable of moving fluid into your brain. So you might have both. That's a pretty tough scenario. Okay, so think about that. Know what HAPE is, know what HACE is. Those are pretty severe, and thankfully, they're pretty rare. We already talked about lightning. The most common result from a lightning strike is cardiopulmonary arrest. Shock the patient as quickly as possible. Shock the patient as quickly as possible. That is the answer. That is the answer forever and ever. Amen. If you have a question about this, they want you to know that lightning causes the heart to go into arrhythmia and the breathing to stop. So good, high quality, early CPR and AED use is the answer. Not the big burns. I talked to you about Black Widow versus brown recluse. Remember it? You can look at the snake bite part. Our big ones are viper and coral. I'll let you look at tick bites. Remember that marine animals are not uncommon for anaphylaxis. To get stung by a marine animal can cause anaphylaxis. To get stung by anything can cause anaphylaxis. If someone was bit by a snake, bit by a spider, bit by a marine animal, bit by a bee, any type of bite or envenomation, and they are now no blood pressure, trouble breathing, wheezing all over, rashes, hives, that is the same as if they had eaten a food or taken a medication that they were allergic to. Treat it with high flow oxygen and epi. All right. When a person is exposed to cold temperatures and strong winds for an extended period of time, they will lose heat mostly from radiation, convection, conduction, or evaporation. And the answer, as I already showed you, since it's about air moving, winds, we're talking about moving air, it's convection. Shivering is in the presence of hypothermia indicates what? Well, if they're still shivering, that's a good thing. I told you that in severe hypothermia, you lose the ability to shiver. So if they're still shivering, that's pretty good. What do you think? C, the body is trying to generate more heat through muscle activity. Very good. All of the following are examples of passive techniques except Druvy, you should get this. If I'm putting warm fluids in you, either enterally or parenterally, which means by mouth or IV, then that's pretty aggressive, right? I'm trying to physically and immediately change the temperature, okay? So then that would be B. It's not common for us to do B unless the patient has no neurological symptoms. If they're still fully with it and they are alert, conscious, and oriented, then that's an option. Here's why it's commonly not used. Because patients don't need active techniques unless they have a neurological involvement. So that's kind of why one is very contradictory of the other. It can be applied. It happens. It can be done. Normally, you would need ALS backup. The most common ways we do this is start an IV and give warm or cold fluids, or we put in a urinary catheter or an OG tube and we enter warm fluids into their belly or into their bladder. And sometimes we do both. So Druvy is not incorrect that we will use the by-mouth route. The difference is we won't let the patient do it. We'll do it for them. We'll put down a nasogastric tube or an orogastric tube. We will put in a urinary catheter, and we will flush the bladder, and we will flush the belly with warm or cold fluids, depending on which one is the emergency, both of which are active and invasive. A woman has frostbite in both their feet, several miles of walking in a frozen field. They're white, hard, cold to touch. The treatment as seen should include. A is a definitely no. We don't rub cold things together. So then that makes D the only answer, because C was looking real good until we got to the whole rub the feet briskly. So D is the answer. 30-year-old male playing softball on a hot day complains of weakness and nausea shortly after experiencing syncope. Appropriate treatment for this patient includes what? Except. Druvy, I want to get this one right. Yeah, so this is the one that Druvy shouldn't be giving anything by mouth to. We would do this by intravenous route. Why? Because the patient now has mental status changes and they passed out. So we want to be careful giving things by mouth. Cooler environment's a great idea. Oxygen's always a good idea. Placing him in supine position and elevating his legs, if he's been having trouble with syncope, also a good idea. I would be careful with D, though. If he's becoming a vomit problem, recovery position would be best for the patient. We don't do things by mouth once a patient becomes a neurological change. You are assessing a 27-year-old woman with a heat-related emergency. Skin's flush, hot, and moist still. Level of consciousness is decreased. After moving to a cool environment, managing airway, administering oxygen, you should do what? First of all, I want to ask you, is this patient a heat stroke or heat exhaustion? Yeah, we're definitely moving towards stroke. The more we get this mental status change, the more we're moving towards stroke. We might not be there yet because they're still moist, but we don't know. If the stroke was fast, if the heat exposure was really fast, maybe they didn't have time to run out of sweat. So you can't be sure, but you can always know that neurological involvement equals stroke. So get this patient to a cold environment, good oxygen, good airway control, and which one are you going to go with? Jason says D. We got to know where to start. I don't hate that. However, I want to treat her. Good job, Ariana. So, yeah, D is a good thing here, but it's not going to address the fact that the patient needs immediate treatment because her consciousness has changed. Okay? I told you earlier that we dunk these patients in ice water tanks. I'd like to know her temperature, but I can get that after I get aggressive treatment on board. C would be active cooling, and it would be really important to do it that way. Okay? Then you would take a temperature. So, Jason, the only issue is do one before the other. Do the active treatment first, then you get that good temperature check. It is important to remove a drowning victim from the water before laryngospasm relaxes because, okay, so I didn't touch on this, but you'll get it in the literature. When we go into the water and we start struggling, we have a reflex, a mammalian dive reflex, that will make us have a spasming of the vocal cords. The whole point of that is to keep water out of the lungs. So if you remove a drowning victim from the water before that laryngospasm relaxes, then you can prevent the water from getting into the lungs. So the answer is C. 13-year-old girl found floating face down in a swimming pool. Witnesses tell you they've been practicing diving. How do we safely deal with this? I told you all about this caution. I have no idea what A is doing. That's just batshit crazy. So Max is correct. Rotating the entire body as a unit is not very plausible in a body of water because mostly things are going to, I'm not going to explain it that way. If you deal with the core, you will control the unit. So the answer is rotate the upper half of the body as a unit supporting the head and neck. It is not feasible to control head to toe in a body of water. And that is why D is the correct answer. Shortly after ascending rapidly to the surface of the water holding a breath, a 29-year-old diver begins to cough pink frothy sputum, dyspnea, and chest pain. You suspect and treat the patient for what? Sudden onset chest pain and shortness of breath. All day long, that's an embolism. PE. I'm worried about a PE. Is it a decompression emergency? Yes, but there are many decompression emergencies, and this one is specifically speaking to acute onset chest pain and trouble breathing. That's a PE all day long. Could it be a pneumothorax? Yes, but you'd have to be reading in. Could it be pneumomediastinum? Yes, but you'd have to be reading in. I also wouldn't expect a pneumomediastinum to produce pink frothy sputum. Pneumomediastinum means literally having air trapped in the mediastinal space. So A is the answer because of acute onset trouble breathing and chest pain being the real big giveaway. What rules out D again? The fact that D isn't specific enough. This one gives a specific set of symptoms. Yes, this is a decompression emergency. However, this is a specific set of symptoms, so I would pick the one that's most specific to it, which is A, PE. Three ambulances respond to a golf cart. I didn't explain this to you. So we do something called reverse triage when it comes to electrical emergencies. In normal triage, if we find people not breathing, we just pronounce them dead and move on because we don't have enough resources to treat people who are about to die or who we know are dead. So in regular triage, if you are not breathing, you do not have a chance. We walk away. In reverse triage, which we do for electricity emergencies, we know that we can save those patients by defibrillating them. So it's reversed. So in this case, 6 golfers struck. All 6 are struck. 2 are conscious and alert. Leave them alone. Next 2 have minor fractures and they're confused. Leave them alone. The last 2 are in cardiac arrest. Well, let's deal with those. The group 3 should be treated first because if we shock them immediately, we're going to save them. So the answer, oddly, in the talk of triage would be the dead people because in this one particular reason, you can probably save them. So it's group 3, which is C. That's reverse triage. In any other type of triage, if you ain't breathing, you'll never be breathing because we're going to walk away. In electricity triage or reverse, we try to defibrillate people who are not breathing and in cardiac arrest. If electricity killed you, it'll probably be electricity that'll save you, which is kind of odd. Any questions for me? It's a big night. Let me pull up the sheet and do a quick roll call. All right, speak up, please. Jamie Beach. Jason Eater is here. Courtney Mag, I think you're here.
Here.
Sherelle. Tia. Alex. Shy, I think you're here. Shy, you still here?
Here.
Okay, Shelly Martin. Sydney Pritchard. Julia Coate. Aiden Novelli. Drunk Perfume, are you here tonight? I didn't see you. Mark Walker, are you here?
Here.
Alex Clark, are you here? Luke Ackerman. Max Alderman, I think you're here. Ella Caston, are you here? Henry Williams. Dominique is here. Ava Mag, are you here? Stephen Harper. Brooke Lavelle. Kiara Lemon. Sarah Ormond. I think you were here, Sarah. Are you still here? Sarah, going once, going twice.
Here.
Oh, good. Ari Diaz. Dhruvi Patel is here. Ari is here. Allison Kiernan, are you here? And Dylan Williams, are you here? Okay, everyone. Thank you for sticking with me. A lot of material tonight. We have 4 pretty nice sized chapters this week, and you'll have a nice discussion board to go with it. So get to work. Here's to a good week. I'll see you in lab. Good night, everybody.